Hi Anjali, can you share the screen? We'll just run through once. If I'm audible, Anjali. Hello. Alright. Hi, Anjali.
Yes, hi.
Hi, Ashwin.
How are you?
Hi, Dr. Yash.
Hi.
Anjali. So, can you just share the screen so that we see there are no issues?
Yes, hi. Hi, Ashwin. How are you?
Some delay in the relay, I think.
No, no. I had switched on the YouTube just.
All
How are
right.
you? Yes. Long time.
So,
Good to see
sorry.
you.
So, screen share. Should I do
Yeah,
this?
yeah.
Okay,
Just screen.
I'm trying. Yeah.
Huh.
Replace current share.
Yeah, please. Okay, I
Okay.
stop. Huh.
Hmm. So, let's. Uh, am I sharing?
Huh, yeah. But,
My slides are
yes.
visible?
Yes. Just, okay, even Anjali has started. Okay, just this one. Anjali, can you share the screen or stop sharing, like anything, something? Huh.
Okay. Ma'am, can you hear me, ma'am?
Yeah, but the volume is low. Huh.
Yeah. Is my screen visible, ma'am?
No. Share your screen.
Is it visible now, ma'am?
Just click and start screen share. Yeah, it's visible now.
Slideshow.
Put it on slideshow.
It's not good.
Anjali, any issues?
Yeah, this computer is just a little bit lagging.
Okay.
Yeah.
Okay, you just go down and see if it's moving at least. Just scroll down and we'll just.
Yeah, scrolling down, but
Yeah. You just close the screen and maybe reopen. I will just start. It will just.
my presentation is gone.
Dr. Ash, you also want to try once? Can you? Anjali, just stop screen now.
Yeah, I'm stopping share.
Yeah. You just close that presentation, reopen. We will try. Otherwise, you just scroll down. It's okay. Otherwise, if you want me to project the slides, that's also fine. Yeah.
It's visible?
Yeah, it's visible. Can you put it on slideshow? Yes, perfect.
Yeah.
Just
Okay.
change.
It's going?
Yeah. Yes.
Fine.
Perfect.
Okay. I'm stop sharing now.
Yeah. Okay. So we'll just start here. Okay. So I welcome all of you. Good evening, everyone. So a warm welcome to everyone joining us today on this special occasion. So today is 1st of February, the World Aspergillosis Day. So we bring to you Aspergillosis 101, decoding aspergillosis from basics to best practices. So we have tried to cover various important aspects of aspergillosis, the spectrum, including the significance of various aspergillus species and the therapeutic drug monitoring. So obviously, it's not possible to cover the entire topic. So we have tried to look into the various salient features of each part or each spectrum. So we have a fantastic lineup of speakers and who are ready to share very valuable insights. So and just to remind you, you are free to comment your questions in the YouTube comments so that we can address the queries at the end of the talk. So without any further ado, let's start. So World Aspergillosis Day is celebrated to raise awareness about this underdiagnosed fungal infection. So why is it necessary that we talk about aspergillosis? It is underdiagnosed and definitely many times misdiagnosed. There is in general public unawareness, including unawareness even among the medical community, and it can mimic various respiratory infections, including TB, like your chronic pulmonary aspergillosis, can be mistreated as tuberculosis. And definitely there is a lot of cases nowadays. Many patients are undergoing transplants, so a lot of immunocompromised hosts and a lot of aspergillosis. And again, the resistance. So the resistance does not spare even the aspergillosis or the fungal infections. And nowadays we are having improved fungal diagnostics, so which can help us to identify the aspergillosis at the earliest. So the spectrum can vary from as simple as aspergillosis, the allergic pulmonary aspergillosis, to invasive pulmonary aspergillosis. So the thing what plays a role is your immunity. So we will look at, I think there are very good lineup of speakers who will be discussing the same. So with that, we'll start with the first talk. The first one is the uncommon manifestation of aspergillosis, a case discussion. I am happy to introduce Dr. Anjali Sebastian. She has completed her MD medicine from CMC Vellore and currently a senior resident in NDM infectious diseases in Kasturba Medical College, Manipal. Over to you, Dr. Anjali, for your case.
Thank you, ma'am, for the introduction. I'll just be sharing my slides. Are my slides visible, ma'am?
Yes. Could you put it on slideshow? Yeah, it's correct. You can.
Okay. Good evening. I'm Dr. Anjali from KMC Manipal. I will be presenting a case to you. This is a 55-year-old lady who is a hypertensive on medication who presented with the chief complaints of lower back pain for 3 months, loss of weight for 3 months, and difficulty in walking for 2 weeks. There was no history of fever, no history of cough and breathlessness, no history of abdominal pain, urinary or bowel complaints, no history of oral ulcers, joint pain or rash, no history of steroid intake, no history of any Ayurvedic or homeopathic medication intake, no history of intramuscular, intraarticular epidural injections, no history of any dental or recent surgical procedures, no history of TB or exposure to TB, with past history of hysterectomy done 26 years back. On examination, her vitals were stable. There was no pallor, no icterus, no clubbing, no cyanosis, no lymphadenopathy, edema, koilonychia. Her GCS was 15 by 15. Her higher mental functions were normal. There were no focal neurological deficits and there were no spine deformities on examination. However, she had tenderness over her lumbosacral region and paraspinal region. All other systemic examinations were within normal limits. So on diagnosis, we were suspecting a spondylodiscitis with a paraspinal abscess. So the differentials that we were considering were tuberculosis, brucella, nocardia, aspergillosis, histoplasmosis, E. coli, or Klebsiella. So she was evaluated at another hospital where an MRI whole spine with contrast was done, which showed D9, D10 spondylodiscitis with subligamentous spread of infection. Along with this, she also had L5S1 spondylodiscitis and with some enhancing soft tissue in the epidural space also. She was empirically started on ATT at the local hospital. On ATT, she however had worsening lower back pain over the next 2 months. She had fever with chills and she had no symptomatic improvement and she continued to lose weight. In view of persisting complaints, she came to our hospital and was admitted under orthopedics, where she underwent decompression biopsy and posterior stabilization, and intraop cultures and histopathology was sent. The histopathology from the L5S1 region did not give us much information. There was no evidence of any granuloma, no evidence of any malignancy also. The gene expert, which is sent from the intraoperative sample, was negative of a MTB on gene expert. There was no evidence of any AFB, and eventually the midget culture also came negative. Aerobic cultures also showed no growth. However, fungal culture showed Aspergillus flavus. So then came the question, is it a true pathogen? So there are several points in favor for her for this being the true pathogen. One, it was an intraoperative specimen that we had sent and she had poor response to ATT, which means it was unlikely to be tuberculosis. However, there were several points against also, as there was no evidence of any fungal elements on biopsy and she had no evident risk factors which could have predisposed her to Aspergillus spondylodiscitis. She did not have any history of severe or prolonged neutropenia. She did not receive any high dose of glucocorticoids. She was not on any immunosuppressive regimen. There was no history of trauma or epidural injection or spinal procedures. And there was no history of any pulmonary involvement also for contagious spread. So in order to look for other sites of involvement, she underwent a CT thorax, abdomen and pelvis, which found to have a 2 into 2 centimeter deep right axillary lymph node, and she underwent biopsy of the same. The gene expert on this biopsy also came MTB not detected, and midget cultures eventually showed no growth. However, the fungal culture grew Aspergillus flavus. So then we came that since 2 different sites had grown the same organism, we thought of considered to be a true pathogen. So we went ahead and looked at all the possible literature on Aspergillus spondylodiscitis in immunocompetent. And we came across several case reports where there has been spondylodiscitis in immunocompetent patients with no evidence of any other risk factor. So she was worked up for any immunosuppressive state. Her HbA1c was normal, her immunoglobulin levels were normal, and her CD4 was 990. HIV testing was also negative for her. So final diagnosis, she was disseminated aspergillosis with spondylodiscitis and lymphadenitis. She was started on voriconazole 300 mg twice daily for 1 day, following which she was put on 200 mg twice daily, with which in hospital itself she started feeling better and she was discharged and advised for voriconazole levels on OPD basis. However, she returned to OPD after 3 weeks with worsening back pain, new onset polyarthralgia, bilateral upper limb and lower limb tingling paresthesias, auditory hallucinations and visual hallucinations. At this point, we sent the voriconazole level, which came very high as 7.6. So we diagnosed her with voriconazole side effects. She had polyarthralgia. She had hallucinations. She experienced both auditory and visual hallucinations. Along with this, she also had limb paresthesias. We got a bone scan done to see if there's any skeletal defects with fluorosis, which was normal. She did not have any hepatotoxicity, QT prolongation, or any other visual disturbances with respect to her symptoms. So we reduced the dose of voriconazole to 75 mg twice daily, with which she was symptomatically better and she was discharged. However, on review in OPD after 2 weeks, her voriconazole level was subtherapeutic range of 0.7. So she was readmitted and restarted on 100 mg twice daily, following which the repeat value was 2.1. She was currently doing well and she's planned for further follow-up on OPD. So take-home message. So Aspergillus spondylodiscitis is not uncommon in immunocompetent hosts. Therapeutic drug monitoring has to be done for voriconazole for adequate drug levels and to avoid toxicity. Thank you.
Thank you, Dr. Anjali. So
Ma'am.
hello.
Hello, ma'am.
Sorry, yeah, there was a network interruption. So yeah, that was a nice case. Like we know. I mean, usually we think of aspergillosis and immunocompromised hosts like neutropenic hosts. So this was a good case highlighting that there can be rare cases or rare instances of aspergillosis, and definitely highlighting the importance of therapeutic drug monitoring of voriconazole, which we had this patient had both high toxicity as well as subtherapeutic levels. So thank you, Dr. Anjali, for this very comprehensive case discussion. So with that, we move on to the next next talk. So basically, managing critically ill patients is already difficult. In that, suspecting invasive aspergillosis in a critically ill patient, in the patients in ICU, is especially suspecting them early is crucial. So we have Dr. Harshvardhan Rangapakuri. He is a associate consultant in critical care medicine in Manipal Hospital, Sarjapur. Over to you, Dr. Harshvardhan, for your presentation on when to suspect invasive aspergillosis in ICU setting. You're muted.
Yeah, can you hear me now?
Yes.
Yeah. Good evening, everyone. Thanks, Akshatha, for giving this platform, spreading the knowledge on aspergillosis on World Aspergillosis Day. So let's dive deep into invasive aspergillosis as much as possible. So starting with the introduction, like aspergillosis, as you know, aspergillosis is a mold widespread in indoors and as well as outdoors with airborne spores, causing infections in specific conditions. The disease spectrum varies based on the host immune response. So whether it is high or low, it depends on the various spectrum of aspergillosis. The spectrum of aspergillosis varies depending on the host immune response. So there are most common aspergillosis organism is Aspergillus fumigatus, and other organisms include Flavus, Pteris, and Niger. So what's the importance of knowing all these organisms is like Niger is most probably the colonizer, whereas Pteris and the versicolor are resistant to amphotericin B, and nidulans is also resistant to the echinocandins. So knowing this species is utmost important in a treatment perspective. So pulmonary aspergillosis is challenging due to diagnostic test limitations and treatment delays and limited options. and as well as drug interactions with resistance patterns. So moving on to the pathogenesis. So it's an airborne infection. As you know, there is an Aspergillosis species which has conadial spores. These conadial spores fly over through the air and colonizes the airway. And these are the conidia, and the receptors is salicylic acid residue, which adheres to the epithelium, and this is get engulfed into the airway epithelium, and there is the neutrophilic reactions activation and phagosomes. Engulfment of the conadial spores occurs, which then these conadial spores germinate into these hyphae, and these hyphae are quite invasive in nature, and it invades your blood vessels and lung tissues, and there could be disseminated infections moving on to the your CNS, gut, renal, and liver pathology. So this is how the pathogenesis occurs for invasive aspergillosis. So as I told you, there's a huge spectrum of invasive aspergillosis based on the immune responses from hyper to low. So this will be dealt subsequently in the talks. So moving on to the invasive aspergillosis per se. So annual incidence of invasive aspergillosis around 3 lakh among 10 million patients are at risk. So you need to know the terminologies, certain terminologies. That is, invasive aspergillosis means the invasions into the lungs, respiratory samples with associated clinical, radiological, and bronchial features. So angioinvasive aspergillosis is nothing but the invasions into the pulmonary arteries, leading to coagulative necrosis, hemorrhagic infarctions and leading to the pulmonary parenchyma. Airway invasive aspergillosis it's just pertaining into the airway part of the your lungs. That is, only it involves a tracheobronchitis or bronchiolitis. It doesn't involve the lower airway disease. So another spectrum, it includes influenza-associated pulmonary aspergillosis and COVID-related pulmonary aspergillosis. We'll deal with these two entities for the slides. So what are the risk factors in which we need to suspect invasive aspergillosis? So your patients might be having underlying risk factors like hematopoietic stem cell transplantations, solid organ transplantations. The patient might be on chemotherapies, and critical illness, critical patients, that is long stay in ICUs, that more than 21 days of ICU stays are all risk factors for invasive aspergillosis. And your viral pneumonias, including influenzas and COVID-19. Obviously, you must have seen during the COVID pandemic, many of us have dealt with invasive pulmonary aspergillosis. And most importantly, don't forget to ask the history about the environmental factors, exposures, that is construction workers. Even in the hospital, construction work can lead to the in-house inpatients, admitted patients at risk for invasive aspergillosis. So there are certain bodies which have given the entry criteria for the invasive aspergillosis. These are the bodies which are commonly used for diagnosis of invasive aspergillosis: EORTC and MSGRC. This is mycosis and European guidelines. And the drawback of this is that this guidelines cannot be used in ICU patients. So there was one more body which came up as ASP-ICU, and which mainly focuses on the diagnosis for the ICU patients. So what's the difference between EORTC and ASP-ICU guidelines is that the ASP-ICU guidelines includes the specimens from the lower respiratory tract should be taken for the diagnosis of invasive aspergillosis. And the further ASP-ICU was modified by the BM ASP-ICU. It includes the fungal markers also, which has such as galactomannan and from the BAL is included in the BM ASP-ICU criteria. So this can be again further divided into proven invasive fungal diseases, probable fungal diseases, and possible fungal diseases. So when to suspect? Your entry criteria that patient is in ICU and having respiratory symptoms, dyspnea, hemoptysis, and chest pain, classical features of any viral pneumonia, and with fever since 3 days, persistent of fevers in spite of giving antibiotics, and chest infills imaging All these are possible findings which we should be suspecting of fungal infections, non-resolving pneumonia in spite of antibiotics, long stay in ICU. So start thinking of fungal infections in such scenarios. So this is the overall graphical representations or the flow map which you need to be working on for the diagnosis. So your patients admitted in the ICU with respiratory symptoms, with chest infiltrates, you should be doing with serum galactomannan, sputum cultures, and the PCR can be done. Bronchoscopies to evaluate further invasive features like pseudomembrane is present or no, there's ulcers or plaques in the tracheobronchitis tree, and your CT scan. So we'll be dealing with each one of these entities individually. So moving on to the utmost important thing, the very first diagnostic test we do in this kind of symptoms is radiological HRCT. So we need to know how to interrupt the CT findings. So we'll deal with this right now. Pulmonary nodules are common presentations with invasive aspergillosis. This can be seen both in neutropenic as well as non-neutropenic picture. But the distribution of the nodules are quite different between the neutropenic and non-neutropenic. The central lobular distributions involves airway invasive patterns, whereas peripheral random nodules confirms the angio-invasive infections. There are specific signs called as halo signs, air crescent sign, hypodense sign, and transfistral sign. So in neutropenic patients and non-neutropenic patients, so we need to be aware that in neutropenic patients, angio-invasiveness occurs within hours, whereas in non-neutropenic patients, there is a slight delay. So the main pathophysiological difference is coagulative necrosis. And here in non-neutropenic patients, you will be having pyogranulomatous inflammation reactions. And typical features of radiological, which we talk about in general, that is halo sign, air crescent sign, hypotense signs, are only seen with neutropenic patients, not seen with non-neutropenic patients as the previously discussed the case scenario. So atypical findings like you need to be aware of tracheobronchial tree thickening, tree in bud appearance, consolidations, and nodules cavitations, non-specific infiltrates. These all features are seen in TB as well. So the patients with non-resolving pneumonia with such features with non-neutropenic always think of fungal infections. And microbiology, there will be positivity of galactomannan in both the scenarios. So this is the halo sign. The halo sign is nothing but the central nodule appearance, and there will be surrounding GGOs. This is because of the angio-invasiveness properties. So the surrounding GGOs is because of the invasions into the blood vessels, which there will be hemorrhagic transformations. You will see the halo-like sign. So this is very specific for the aspergillosis. Even before the mycological diagnostic test, with this CT findings, you can go ahead and treat your patients with antifungal agents. So please remember, and this is the very early sign of the invasive aspergillosis. So this is the halo sign. And the next sign we need to be looking for in CT scan is hypodense sign. This hypodense sign is seen with CCT, that is contrast enhanced CT should be done. It is usually looked in mediastinal window, where you can see the central nodule will be hypodense in nature. There will be hypodense enhancement. There will be no enhancement of the nodules per se. So suggestive of fungal origin. And another, this is centrilobular distributions of the nodules, which again tells you the invasiveness of the fungal infections. So next sign is transfissural sign. So this is the fissure of the lung, and this is the nodule which has been extending beyond the transfissural sign. So as you know, any infections which is pertaining to the lung will be contented by this fissure. So fungal is such an invasive pathogenesis is that it invades the fissure and goes into the surrounding parenchyma as well. So it all tells us about how invasive and how aggressive is the fungal growing up. So this is called as transfissural sign. So usually this sign is seen in carcinoma as well. So if the patient is having the loss of weight, chronic history of cough, obviously, and you see there is transfissural extension in that particular scenario, also you should be thinking of carcinoma. And this is typical of bronchopneumonia picture. Along the bronchus, there will be consolidations happening. So this is how you have to be looking up for signs of fungal infections. So next important sign which we usually read is air crescent sign. So here you can see the patient with dense consolidations with air bronchogram in the nature, and after the treatment with the antifungal, there is necrosis happening and air is filled, and this is called as air crescent sign. So whenever you see air crescent sign at first time of your diagnosis, so please remember that your patient is already lost some of its precious time in treating the antifungal, because air crescent sign happens much later in the course of the disease. So sometimes you also may encounter like miliary aspergillosis, and there are also an entity called as reverse halo sign or atoll sign. Reverse halo sign is nothing but there will be gigios in center surrounded by the consolidation, thick consolidation patch around that. This is also not that specific to the invasive nature, but yeah, if something is seen like this with a background of all the risk factors, then obviously we can go and start the antifungals in this patient. So our next sign is vascular occlusion sign. So usually if there is a consolidation, this is dense consolidation, the vessels are usually will be patent along the consolidation. But in vascular occlusion, there will be a cutoff of the vessels per se. So this is called as vascular occlusion sign. And this can be also seen in mucorous infections also. So in acute fungal tracheobronchitis, usually radiographic features will be normal, and in such scenarios, there will be bronchoscopic findings will help you in ruling out the acute fungal tracheobronchitis, where you'll be able to see the pseudomembrane formations and plaques and nodules with peribronchial infiltrations. So as I told you, at diagnosis. Sorry. At the diagnosis, there is nodules with or without halo. At 1 week, there will be again hypodense sign, and at the later stage of the diseases, you can see air crescent sign, cavitations. All this can happen into the clinical scenario. So moving on from the radiology to the cultures perspective, aspergillosis grows rapidly in the cultures. Delaying therapy with confirmations should be avoided. Negative cultures are common, especially in the transplant recipients. Predictive values for positive cultures varies by patient populations, and BAL cultures have higher predictive values in certain cases. So biopsy can be taken from sterile sites as well as non-sterile site. Okay, what is meant by sterile site? Sterile site is nothing but your pleural fluid and lung biopsy per se. Non-sterile sites could be your BAL. So from here, you can send the specimens for the histopathological examinations. And as you all know, the aspergillosis is a narrow spectrum and branching acutely at 45 degrees with septated fungal hyphae, whereas mucor is always in the 90 degree with broad septate hyphae. This is how you differentiate between these two entities by the histopathological examinations. And also remember, there are certain species which have features just like aspergillosis, that is Scedosporium and Fusarium. Therefore, identifying of the species is much more important because the treatment might vary. So moving to the fungal biomarkers, this is one clinical paper which they have studied about the IgG antibody, which is against the specific for the aspergillosis. So if cutoff, they have used this more than 80 AU per ml, and aspergillosis has IgG has similar sensitivity to BAL fluid galactomannan, but has lower specificity at this cutoff. So combining positive result of aspergillus IgG or BAL fluid galactomannan increases the sensitivity, but decreases the specificity compared to the BAL fluid galactomannan alone. So we can use this marker in diagnosis of aspergillosis in this order: the BAL fluid galactomannan, and then aspergillus IgG specific, and then serum galactomannan is of more diagnostic value. So remember that this antibody takes some time, at least 10 days, to come into the picture. So initially, if there is negative, you cannot rule out aspergillosis completely. So non-culture diagnostic tests include the galactomannan. Galactomannan is, as you know, it's a fungal cell wall polysaccharide which has been secreted in active invasive phase, and the cutoff varies from 0.5 to 1. So 1,3 beta D glucan is also utilized in the diagnostic test, and the cutoffs is between 60 to 80 picogram per ml. Aspergillus DNA PCR can also be used for diagnosis of invasive aspergillosis. So moving on to in detail about the galactomannan, there are the tests which FDA has approved for the WHO, and FDA have approved the Platelia ELISA based galactomannan test and lateral flow assay by IMI diagnostic test for diagnosis for galactomannan. And these are the cutoff values which is used for the different serum different samples. So in non-neutropenic patients, also remember that the cutoff value is slightly low of 0.5 is used. So you have to be aware of certain false positives in galactomannan because the false positives can be seen with certain antibiotics like piptaz or because of tazobactam. Tazobactam is also uses aspergillosis in its production. And your dialysis membrane, your gauze spaces, any cellulose-based membrane, all these are causes false positive. And also remember that IVIGs and your blood and blood product bags, there are certain bags which have been utilized for blood transfusion, which causes false positive result. That is one company called as Fresenius bag from Germany is most important to rule out that if your patient is receiving blood transfusions with Fresenius bag from the Germany, because that bag is known to cause the false positive results for galactomannan per se. So moving on to the PCR test. PCR can be again done with your all the samples, serum, plasma, whole blood, and bile fluid. PCR is useful in immunocompromised individuals, underlying malignancies, but one thing you have to keep in mind is that there should not be any antifungal prophylaxis for this. The test is often validated using Aspergillus fumigators, and you can also detect the resistance patterns for this test. There is good sensitivity and specificity for PCR as well. So novel the markers for testing invasive aspergillosis is there's something called as eNOS technology, which uses exhaled breath like 2-phenylfuran, which upcoming and yet to be still prioritized, but it is into the market. So point of care, what you have for point of care diagnosis of aspergillosis, we have lateral flow assays for diagnosis of aspergillosis, either extracellular glycoprotein matter or lateral flow assays for detecting galactomannan. Sensitivity and specificities are around 70%. So these bedside testing can be done very rapidly, and it also saves your much longer waiting times than other biomarkers for the fungals. So putting all this together, from now we have read about the host criteria as well as clinical criteria. Clinical criteria includes your CT scan. If both these are present, then it is called as possible invasive aspergillosis. If along with this, if your microbiological criteria are met, that is any galactomannan is positive, then it is called as probable invasive aspergillosis. But if you have a proven histopathological diagnostic or PCR test, then it is called as proven invasive aspergillosis. So please remember all this proven, possible, and probable invasive aspergillosis doesn't matter in your clinical practice. So all this proven, possible are just for epidemiological and clinical studies which they have used to categorize the invasive aspergillosis. But your suspicion is high in your patients with just possible invasive aspergillosis, you can still go and use the antifungals in such therapies. So these are the bodies which have tried to utilize the criteria: URTC, MSG, ASPICU, and BMS ASPICU. URTC was initially came up in 2008, which was revised in 2020. So they have revised certain host factors. They have included more host factors. Initially, it was just hematopoietic stem cell transplantations. Now they have included solid organ transplantations as well with the B cell immune suppressant diseases, your granulomatous host cell diseases, all these risk factors have been extended in 2020 guidelines. And the difference between URTC and ASPICU, as I've already told, the ASPICU involves positive respiratory, lower respiratory tract sample should be considered here. And this helps in knowing whether our patient is having invasive infections versus colonizations. And BM ASPICU, as I've told you, mycological criteria that any galactomannan was added to ASPICU. So these differences, you have to know what is the difference between these through three diagnostic modalities which we have. So moving on to the influenza-associated pulmonary Aspergillosis. Here, you should be having influenza-like illnesses, positive PCR tests, and temporal relations. And influenza-associated pulmonary Aspergillosis can be divided into two entities. Either it could be tracheobronchitis entities or generalized entities. Without tracheobronchitis, that means your whole lung is involved. The main differentiation feature is that this is localized disease, this is generalized disease. The biopsy can be taken by the membrane per se and checked for the hyphal. Here you would need to do the lung biopsy per se. And other probable diagnosis includes the same in both the scenarios. So recently in our ICU, we have one patient with influenza-associated pulmonary aspergillosis. I just got the video which was sent by my colleague. It shows extensive pulmonary membrane, pseudomembrane formations with white flakes around that. She presented with the history of bronchial asthma with atopic dermatitis with shortness of breath. Then there was ARDS, usually suspected, not suspected fungally initially, and then the ball galactomannan was sent in order of, in view of history-wise, she was having atopic dermatitis and IgE levels more than 1,000. So invariably in such scenarios, the fungal infections was kept in mind and galactomannan was sent. Voriconazole was also started, and day 4 of the illness, we got a ball done, and there was complete membrane formations and pseudomembrane. We have pruned the patients and started voriconazole and yet to see how she reacts to that. So these are some of the differences between invasive pulmonary aspergillosis, influenza pulmonary entity versus COVID. So the main differences you need to remember is that corticosteroid therapy is not useful in this scenario. Corticosteroids can be used here, and angioinvasiveness is more aggressive in influenza related, but it is low incidence in COVID. And the risk factors of mortality is also 4-fold increase with influenza associated pulmonary. So switching on to the treatment perspective. So as we know, we have 3 classes of antifungals, mainly polines, triazoles, and echinocandins. So historically, aspergillosis was treated with the polines group, that is deoxycholate amphotericin B, which showed the good results back then. Once the introductions of triazoles with the voriconazole was compared with the deoxycholate, and the studies showed exceptional results where voriconazole showed good mortality benefits and clinical improvements stages. So now the drug of choice, first drug of choice which is recommended by all the bodies is voriconazole, and it's given by the dose of 6 mg per kg BD day 1 intravenous, and then 4 mg per kg BD for 7 to 8 days. And theoretical drug monitoring is usually done at around 7 to 8 days of the therapy, and it's monitored around 1 to 5 mics per ml. So anywhere between this should be your maintenance therapy continues above that. Next, you need to be aware of the side effects, as my other colleague also talked about the voriconazole toxicity in our previous case. So that also should be kept in mind. So one side effect of isavuconazole you need to remember is that the only azole which causes shortening of QT. So all azole causes prolonged QT intervals, but this azole causes short QT syndrome. So avoid this in any short QT patients. So another group of drugs is echinocandins. Caspofungins is FDA approved, only FDA drug. If someone asks you that this is caspofungin, is only FDA drug, but Anidula fungin, mica fungins are all equally efficacious in for invasive pulmonary aspergillosis. So the combination therapies have not been recommended by any guidelines, but the combination therapies can be used with case-to-case basis. And if the patient is worsening and there is azole resistant in your scenarios. So if the azole resistance is more than 10%, obviously the combination therapy is way to go. What combination therapy? Azole plus echinocandins is caspofungin can be used. But do not use combination therapy of your polyenes versus azoles, but that doesn't work because of the mechanism of actions on the membrane per se. And if there is any suspicion of your aspergillosis versus mucorales initially, so better start with polyenes, your amphotericin B. Then, if your lab diagnosis gives you aspergillosis clue that's galactomannan positive, shift to the the voriconazole therapy. And if there is any doubt, if a patient is having both the aspergillosis as well as mucorales after starting of amphotericin B, then always you can switch to the posaconazole and isavuconazole, which treats both of these entities respectively. So these are the antifungal strategies. IDSA and ECL guidelines all recommend voriconazole, and voriconazole as first line of choice. And refractory progressive invasive aspergillosis, always check out the TDF monitors, and immunosuppressive therapies should be tapered, and surgery should always be considered in such scenarios. And if there's intolerance, again switch to the better azole tolerating drugs. Prophylaxis, I'll not go deep into the prophylaxis, but the first line of prophylaxis is always posaconazole by all the bodies. This is the ECIL, that is leukemia body of by European guidelines also recommend posaconazole as prophylactic drugs. So when to discontinue your antifungals? Your antifungals can be discontinued with all these criteria are met. That is, there is resolutions of the neutrophils, and then antifungal therapy 4 to 6 weeks is completed. There is no signs and symptoms of invasive mold infections, and at least 2 follow-up CTs shows resolutions of the symptoms. And the resolution of the symptom, then you can discontinue. And if there is any residual lesions, then obviously go for PET scan. And if there is positive, continue antifungals. And if only one of these criteria are met, your antifungal therapy should be continued and reassess your diagnosis again. So these are certain last slide, and very important slide which we need to consider in special scenarios, that is uncontrolled disease, adequate management of underlying diseases like immunosuppressives and treat the underlying cause. Persistent immunosuppression, reduce the immunosuppressive doses, and if there is no accurate diagnosis, reassess your diagnosis, and always think about the co-infection. Co-infection is utmost important. Influenza patients, just don't treat influenza. If an influenza patient is not responding to the standard line of treatment, think of fungal infections, and as well as bacterial co-infections also should be added accordingly. And drug resistance should be always kept in mind. Primary drug resistance, because of the species identification, as I've told you, certain species are resistant to certain drugs. Species identification is utmost important, and acquired resistance depends on your ICU, and your azole susceptibility testing should be done. And PK/PD levels, your drug monitoring should be continued. And one more important entity is that of iris. So I will tell you a clinical scenario that you have started antifungal. Imagine the same patient which I've told you have started antifungal, and after a few days into the course of antifungal, your patient still deteriorates, and there is deterioration of fungal infection per se, or it is because of the iris. It can be excluded just by ruling of these conditions, like serial monitoring of galactomannan. If the galactomannan is decreasing trend, then obviously your fungal infection is reducing, and there is good immune responses, and this all reaction is because of immune related responses. Then you can add steroids per se. So this is how we can use the serial galactomannan monitoring in ruling out the fungal infections attributing to the iris per se. So yeah, this is from my side. Thank you.
Thank you, Dr. Harshvardhan. That was quite comprehensive, from pathogenesis to the various spectrum of invasive pulmonary aspergillosis till the treatment and the toxicity. You have covered everything. So I'm just checking for any queries. Currently, I don't see any queries in the chat in the YouTube as well. So thank you once again for making time from your busy schedule and being a part of this webinar.
Thank you, Akshatha, so much.
So without any further ado, let's move on to the next talk. So the next one is all about the importance of knowing the various species of aspergillosis. So it is taking us through this journey of the importance of speciation in the diagnosis as well as management of aspergillosis. We have Dr. Nikhil John. He is a senior resident in PSG Institute of Medical Sciences and Research, Coimbatore, Tamil Nadu. Over to you, Dr. Nikhil.
Am I audible, ma'am?
Yes, Dr. Nikhil.
Good evening, all. It's a very nice presentation, both from Kirti ma'am and from Harshvardhan sir. Kirti ma'am went through a nice case scenario, and Harshvardhan sir compiled the whole of invasive aspergillosis for us. Now, coming to a bit of the clinical microbiological part as to the importance of Aspergillus species identification. We all know the spectrum of disease that Aspergillus can cause invasive, can cause allergic manifestations, so it can cause respiratory infections. So why is the identification of species per se is important when it comes to Aspergillus? Why not just report Aspergillus species, or why not just treat it as a whole, as one organism, as Aspergillus species? There will be a lot of pitfalls if we follow that route. So in this presentation, we'll look into the importance of Aspergillus species identification. I'm not able to change my slides, ma'am.
Okay. Can you reshare? Stop
Just
share and reshare.
no, ma'am, I'm not able to change my slides.
Okay. Can you share it? Or you
I'll,
just
I'll,
put it on.
I'll
Yeah.
just,
Don't put it on slideshow. You can scroll through if at all.
okay, ma'am, I'll do that.
You can increase the size of the screen. Yeah, try with mouse sometimes. Maybe. You close the comments.
It's changing now, ma'am. Yeah. Sorry for that hiccup. So as we start with Aspergillus species identification, you must all be aware of the American elections which went by. Trump won. Some people are happy and some weren't. So we'll start with God bless America and of course God bless India. And I put something in the brackets which says Americella. That's one of the sexual stages of Aspergilli. So why I'm starting off with a religious note is that in 1729 there's this priest named Micheli who first identified the structure of Aspergillus and named it so because he felt that this Aspergillus resembled the instrument used to sprinkle water in the holy services. So with that, we'll go into the Aspergillus species proper. So here we are able to see. I'll zoom into this section. You're able to see that this Aspergillus species, there are so many subgenuses, there are so many sections. You must have heard of fumigatus, nidulans, flavus. So many species are there, and this may cause us to be put into a situation where we feel we are lost in a maze. So in this presentation, we'll equip ourselves with tools so that we'll find a way to go through this maze. Excuse me. Sorry for that hiccup. Yeah. So continuing. So coming to the classification of Aspergillus, it belongs to the family Aspergillaceae. In genus Aspergillus, you have several subgenera like Nidulantis, Circumdatae, Fumigatae, Cremae, and Aspergillae. So inside this, you're able to see there are several sections. What we do in our routine clinical microbiology lab is that we report it as Aspergillus species or Aspergillus species complex, and several times most of the times we do not report the subspecies or the species within the said section. So for this, we require the presence of molecular tools, and just morphological identification won't suffice. So looking at the various diagnostic modalities usually used to diagnose aspergillosis, we have microscopy, culture, histopathology. These all form our conventional methods. They have their own advantages and disadvantages. Then we have a serological methods which Harshvardhan sir went through. We have beta-D-glucan assay and galactomannan, and we have a molecular test like PCR, and we'll be looking in detail into these molecular tests as to what fungal targets we'll be using and how to identify the individual cryptic species and the importance of these cryptic species. So here, this is a study in 2017, an Austrian-based study. Here you're able to see the different parameters involved and different sensitivity specificity profiles of these studies. You're able to see the performance of various tests, and this tells us that the present and future of aspergillosis diagnostics is more of a combination testing. So here, the combination of PCR, galactomannan and BAL, galactomannan serology and culture gives us a good sensitivity of 95% and specificity of 75% and specificity of 95%. So here you're able to see the cell wall of Aspergillus fumigatus, both the hyphal cell wall and the conidial cell wall, important components being galactomannan and 1,3 beta-D-glucan assay. So these are used for this serological and non-culture based diagnosis of Aspergillus species. Here you're able to see this is the galactomannan assay put out by Biorad, Platyella elisa. The galactomannan, as we saw, is part of the Aspergillus cell wall. So the sensitivity and specificity are variable. Sensitivity is 22 to 90% in serum, and specificity ranges from 80 to 70%. So there are a lot of variability here. And there's another similar kit from a Dynamicer, a Chinese company, for the non-culture based identification of aspergillosis. It's a POCT test. So this tells us the various spectra of fungi these tests, both galactomannan and beta-D-glucan, they form. So right in the center, you're able to see that within both the circles of beta-D-glucan and galactomannan, you're able to see the presence of aspergillus as well as with other species also. Point to be noted, you're able to see that mucorales is outside all circles. So this is a flow chart where beta-D-glucan and galactomannan can be used in tandem for the diagnosis of a pulmonary nodule patient with pulmonary aspergillosis. So coming to the microbiology proper. So what are you going to look at as soon as you look at your culture plate? Say you have a Sabrose dextrose agar plate in your hand and you feel that an aspergillus mold has grown on it. So what is the routine pathway? So you have a sample which is sent to you. You do a KOH mount directly. Say a BAL sample is sent to you. You do a KOH mount. So what are you going to see if aspergillus is there? Aspergillus, what are they? They are hyaline septate hyphae with shows acute angle branching, right? So you'll be able to see that on your direct microscopy. Sporulation won't be much appreciated on direct microscopy. You'll have to grow the organism on culture. Say you grow it on Sabrose dextrose agar. There are other agars like Zapex agar and all, but in routine we are using Sabrose dextrose agar. So what are you going to see? You're going to see the macromorphology and micromorphology. Macromorphology, the colony growth rates, the colony's front side obverse, colony's reverse, colony texture, color of the mycelia, presence of soluble pigments and exudates, if any. Going into the micromorphology, what are you going to see? You're going to see the hyphal characteristics. As we said, there hyaline septate hyphae with acute angle branching. You're going to see the seriations. This is an important component with respect to micromorphology, the seriation. We'll be able to know whether it's uniseriate or biseriate. It will help us to differentiate various complexes in our aspergilli. Then you have the vesicle, you have the conidia, you have the stipe, you have specialized structures like Pule cells, Cleistothecia, and ascospores. So this is a beautiful image from Laron. Here on the left side of your screen, you're able to see a uniseriate Aspergillus species, and on the left side, you're able to see biseriate. Why do you call it biseriate? Because the conidia sits on your phyllide and medulla. Conidia, phyllide, medulla, CPM. Conidia sits on phyllide and medulla. Then it is called biseriate. Whereas in uniseriate, directly on the vesicle, you directly have a phyllide. There is no medulla. You're able to see another structure also in Aspergillus, which we call as the foot cell, which is present at the base of the conidiophore. Again, this is a beautiful image from David Ellis. You're able to see uniseriate and biseriate Aspergillus species. Biseriate having conidia, phyllide, and medulla complex on the vesicle. So this part, which is present near the, which is present on the conidiophore below your vesicle, is called your apex of the conidiophore, and that part is called stipe. So this is again what we are going to see in our macromorphology and micromorphology. So always remember those important structures: Houlet cells, Cleistothecia, and ascospores. So coming to our shape of our vesicle. So here we have different shapes. You're able to see a globose vesicle, you're able to see a pyriform vesicle, you're able to see a spatulate vesicle, you're able to see a clavate vesicle. So based on different shapes of our vesicle, we are able to differentiate our Aspergillus species also. So as we said, the seriations are important. So here we have a flow chart which has simplified things for us, saying that if it is uniseriate, it is going to go in the direction of fumigatus, glaucus, clavatus, and others. This is just a simple identification. This is not a foolproof identification, but this will help us to navigate through the maze. When it's biseriate, it can be niger, tereus, nidulans, vesicular, ustus, and others. Whereas it is uniseriate and biseriate, it can be flavus, ochreus, oryzae, and others. So coming to our uniseriate group, which has fumigatus, glaucus, and clavatus. Fumigatus, you're able to see they can be blue, green. Glaucus, ascocarp is usually present. It can be yellow, green, or brown. On the obverse, Aspergillus clavatus, as the name tells us, it has a clavate vesicle, a smooth, hyaline, dense, felt of conidiophores. Now coming to fumigatus, it's a more commonly isolated species of Aspergillus. You're able to see the gross morphology. The rate of growth is rapid, matures usually within 5 days. An important feature of this is that it has the ability to grow at 45 degrees Celsius, which helps us to differentiate from other species. On the obverse side, you're able to see a velvety, powdery colony in shades of green, and there's a narrow white border also. The reverse, you're able to see it's white to tan. So on the micromorphology, you're able to see hyaline septate hyphae. The conidiophores are smooth and relatively short. The phyllaids, again, as we said, here they are uniseriate. They are closely together, forming only on the upper 2/3 of the vesicle parallel to the axis of the conidiophore. Again, keep in mind, we are going to summarize our Aspergillus species based on how much the conidial complex covers your vesicle. Some Aspergillus species covers 2/3 of the vesicle, whereas some Aspergillus species cover only 1/3 of the vesicle. So this fumigatus, this covers 2/3 of the vesicle. It is parallel to the axis of the conidiophore as a columnar formation. The conidia are round, smooth, and are 2 to 3.5 micrometer in diameter. Now coming to the other group. This is the group which is biseriate. You have Aspergillus niger, Aspergillus nidulans, Aspergillus ustus, Aspergillus tereus, and Aspergillus versicolor. So a lot of important pathogens are covered in this group. So here you are able to see an important pathogen here. What is it? This is Aspergillus tereus, identified by the tan to cinnamon color appearance on your obverse. The texture is velvety and powdery. On the reverse side, you're able to see a yellow and tan appearance. Again, there's some problem with the screen moving. I'll just stop and resume again. Yeah, so we resume. So coming to the micromorphology of Aspergillus tereus, the important thing to note here is the phylides are biserrate. The medulla and phylides are in equal lengths. Here you are able to see the conidia. It is present on two structures. You are able to see two conidia are there. Below the two conidia, you are able to see a phylide and a medulla. Both this medulla and phylide are equal in length. Here it forms only on the upper half of the vesicle. They are compactly columnar. Here again the conidia are round and smooth, 2 to 2.5 micrometer in diameter. Like all other Aspergillus, here they have hyaline septate hyphae. The conidiophores are smooth and relatively short. So coming to a few cryptic species within this Aspergillus teres complex. So Aspergillus alabamensis and Aspergillus niveus are a few important cryptic species that can be potential human pathogens. Teres can be distinguished from other members of the teres section by sequence analysis of a specific targets called beta tubulin, calmodulin, and actin. We'll be looking at these targets as to why they are important. We have generally heard of ITS sequencing, internal transcript spacer sequencing, but when it comes to TRS, ITS can only tell us that it is TRS complex. You cannot go further down into your cryptic species. Okay, now coming to our next important member, Aspergillus niger. By the color, you're able to see it is black with the white border, and on the reverse, you're able to see it's white and cream. Here, Aspergillus niger, you're able to see that the phylides radiate around the entire vesicle, and again, you're able to see it is biserrate. The medulla are twice as long as the phylides. Last slide, what we saw for TRS, both have equal length, both the phylide and medulla. Here, the medulla is twice as long as the phylide. Here, an important thing is the conidia appear dark because what are we dealing with? We are dealing with Aspergillus niger. So naturally, the conidia are dark here. Here, near the conidiophore top, the apex area where the conidiophore ends, it may be brownish in color also. It also has a foot cell. So some of the cryptic species within Aspergillus niger, the rare culprits here are Aspergillus acidus, Aspergillus aculeatus, Aspergillus brasiliensis, and Aspergillus tubangensis. This Aspergillus tubangensis is an emerging pathogen with potentially threat it can cause with respect to your antifungal resistance. It has a few antifungal resistance associated with it. So this species of Aspergillus niger, there are 26 species in it. Aspergillus niger is most common. Here again, beta tubulin and calmodulin sequencing can be used. ITS sequencing only will tell us will give us a rough classification. So again, here next we have Aspergillus nidulans species here. A trivia question for everyone, for all the antimicrobial buffs here. Aspergillus nidulans, why is it important? Because Anidula fungin, one of our echinocandins, the echinocandin molecule was derived from Aspergillus nidulans, A nidulans and Nudula fungin. Okay, so coming back to our Anidula fungin complex, the obverse you're able to see the surface is velvety green, buff to yellow, can be purplish or brown in certain areas. If the Cleistothecia is present, it also has a white border. On the reverse, you're able to see this buff can be orangish, sometimes reddish, purple also. So here this nidulans is important because here we are going to see about two important technical terms, which is Cleistothecia and Hulle cells. Okay, so here you're able to see our Aspergillus nidulans complex here. Here again, what is important in this? The phylides are biserrate with medulla and phylide being equal in length, similar to niger. They form only on the upper half of the vesicle. The conidia are round. Here the conidiophores are usually short. And as usual, you are able to see hyaline septate hyphae. Here again, this large round structure is your Cleistothecia. The small structure here you are able to see is your Hulle cell. We'll be seeing in detail what they are. So this is your microscopic morphology. The sexual state exhibits your Cleistothecia. We said no. This Aspergillus nidulans, the sexual state is called Emericella nidulans. It exhibits this round Cleistothecia, this huge structure which you're able to see. It's almost 100 to 250 micrometer in diameter. You will be able to see even under low power field. It produces red ascospores upon extended incubation up to 14 days. The Cleistothecia are commonly surrounded by numerous round Hulle cells. So this term Hulle, as you know, it is not English. It is again comes from German. We'll see what it means in the upcoming slide. So this cleistothecium is a large, fairly round, closed, mini cell structure in which asci and ascospores are formed. As we know, Aspergillus belongs to Ascomycota. So naturally, this sac containing structure has a lot of asci in it. And once this is burst, this asci they burst, your ascospores are released. So coming to Hulle cells. These Hulle cells are thickened, large, sterile cells with a small lumen. They are associated with cleistothecia produced by sexual stage of some Aspergillus species. Droplets of exudates on the surface of the colony may indicate the presence of Hulle cells. So what is this Hulle? Hulle actually translates to a bubble envelope. Here you are able to see two septations within here in this slide. You are able to see two septations, right? Ascomycete septum, which is the inner septum, and the basal septum, which is the outer septum, the inner round and the outer round. Ascomycete septum has a lot of these organelles known as Voronian bodies. Those are the internal structures that are going to go and plug into your hyphae whenever there is going to be damage into the hyphae. And this basal septum is the surrounding wall, which is going to connect it to your cleistothecia and other Aspergillus structures. So it's important Viva question which people regularly ask is what are the different Aspergillus species where you'll be able to see this Hulle cells. So this Hulle cells, as we said, it means bubble envelope. See, you're able to see an outer layer which is a paper layer, inner layer which is a bubble wrap layer. So two layers similar to the Hulle cell. So the Aspergillus nidulans and heterothalicus, these are associated with cleistothecia, whereas Aspergillus ustus and Aspergillus protuberus, they are not in direct contact with cleistothecia but are present in masses. This Hulle cells of nidulans is globose, whereas of ustus it is more elongated. Now coming to a few rare culprits within the nidulantis section, you have Aspergillus sidovi, Aspergillus ungui, Aspergillus rugulovalus, and Aspergillus tetrazonus. These all may sound a bit like tongue twisters. We just have to know that such cryptic species exist. So ITS sequencing is sufficient to identify only two species complex. So in order to go further into these cryptic species, we need to have your ABCs. So what are they? Actin target, beta tubulin target, and calmodulin target. If not for ITS, we go into ABC. So we'll be discussing in further slides what this ITS, ABC all stand for and where they are present. So coming to Aspergillus species, which can be both unicerate and bicerate, the important one being Aspergillus flavus, others being Oryzae and Ochreus. So here coming to Aspergillus flavus, again one of the most common isolates of Aspergillus that you will see. On the obverse, you're able to see a surface which is green to olive, often with specks of yellow with a white border. The texture again is velvety to cottony. On the reverse, you're able to see a yellowish to tan pigmentation. And coming to the microscopic morphology, you're able to see when fully mature, the walls are rough, spiny, especially at the apex. Here you're able to see where the conidiophore ends and where the vesicle starts. You're able to see prickly structures coming out of the conidiophore. This is an important identification feature of Aspergillus flavus, especially on mature isolates. So here they can both uniceriate and biceriate phyllodes are present. They are formed fully covering the vesicle. We said no, some species cover 1/3, some species cover 2/3. So this is almost fully 2/3. It covers the vesicle. They are loosely radiate and may cluster to form columns of conidia with age. The conidia are 3 to 6 micrometer in diameter with smooth walls. Mature colonies may have rough walls. So some of the cryptic and rarer isolates within your Aspergillus flavus complex is Oryzae, Avineus, Tamari, Alliaceus, and Nomius. Again, here the importance here with respect to Aspergillus flavus is your aflatoxin production. It's an important mycotoxin of clinical importance. So several species of section flavi produce aflatoxins, among which aflatoxin B1 is the most toxic of the secondary metabolites produced by fungi. So this is sort of a summary slide for the 1/3 and 2/3 vesicle arrangement which we discussed earlier. So Aspergillus fumigatus has 1/3 of the vesicle covered. Aspergillus terreus has 2/3 of the small vesicle covered in two layers of phyllodes, that is bicerate, and has alluroconidia along the hyphae. Aspergillus flavus and niger have vesicles completely capped by one layer of phyllodes, whereas Aspergillus niger, again, it has an occur conidial head at microscopy and produces black colonies on culture media. Okay, coming to our molecular problem which we are talking about. So the success of molecular identification depends on the choice of a reliable target target sequence or a gene. So what is a good reliable target? It should be present in multiple copies so that there is good PCR sensitivity. It should have an optimum size, say 500 to 800 base pairs, which is short enough to be sequenced with an automated sequencer and long enough to provide adequate information for identification. The presence of sequence information should be present in the databases. Example, Westerdijk University in Belgium, in Netherlands, they have a database. The Utrecht University in Belgium, they have a database. So it should match with all these databases. They should be relatively conserved while using them as a pan-fungal primer so that it ensures amplification from a broad range of fungi. So following amplification, variable regions within the amplicon are desirable for species and genus level identification. So these is what an optimal fungal target should have. And as we said, a few fungal targets, what did we see? ITS, actin, beta tubulin, and calmodulin. So we'll see what first ITS is. So the most successful molecular target that has been consistently used for molecular identification of fungi is your ribosomal DNA, the rDNA complex. It's a multi-copy sequence of genes that codes for ribosomal RNA. In eukaryotes fungi, this gene complex consists of an 18S small subunit, a 5.8S subunit, and a 28S larger subunit. Interspersed between these gene segments and separating them from one another are regions called spaces. You're able to see here ITS1 and ITS2, internal transcribe spacer 1 and internal transcribe spacer 2. So the ITS1 and ITS2 are variable among species, making them good targets for species identification. Other regions of the rRDNA are conserved, so they can only be used for genus level identification. So in 2012, the International Fungal Barcoding Consortium recommends to use ITS regions can be used as primary target for fungal identifications. So this ITS regions usually have 600 base pairs long. We said a good target should have 500 to 800, right? So they show great variability and a good discriminative power. But in some genera of Aspergillus, Cladosporium, Fusarium, Penicillium, and Trichoderma, the heterogeneity of the ITS1 and 2 regions between species is not sufficient to provide individual species identification level. That is into the cryptic species identification level. In such cases, ITS can only provide a report saying species complex level. It cannot go into the members of the cryptic species. So for discrimination at the cryptic level, we require additional markers. So what are these additional markers? You have genes like beta tubulin, calmodulin, and actin with respect to Aspergillus. There are other targets also which are used to detect other microorganisms. Example D1, D2 for mucorales, elongation factor 1 for Fusarium, RBP1 and RBP2 for Fusarium, Penicillium, and Talaromyces, and several other species. So this is again a list of those fungal targets which we discussed. So here, coming to this fungal target, which is a beta tubulin, you're able to see these beautiful blue color structures in the cytoplasm. They form the microtubule in the cytoplasm. They have GTP and metal ion binding capacity. It has GTPS activity and it is involved in cytoskeletal organization. So it's an important fungal target for Aspergillus. Coming to calmodulin, you're able to see this blue plug-like structures here. They are the central plug in the spindle pole body. They have calcium ion binding function. That's why it is called calmodulin. It has enzyme modulating activity. So hence calmodulin, enzyme regulator activity. So it helps in the spindle pole body organization. So why are these cryptic level species identification important? So the main question all lies into your antifungal resistance and your antifungal resistance profile. So now we'll discuss how the 3 commonly used classes of antifungals are affected by the isolation of such cryptic species. Your common classes, including your polyenes having amphotericin, your echinocandins having caspofungin, anidulafungin, and micafungin, and your azoles having azoles like voriconazole, itraconazole, posaconazole, and isavuconazole. So coming to amphotericin B. So amphotericin B, what is the problem with amphotericin B here? So how does amphotericin B act? Amphotericin B acts by inserting itself into the fungal cell cytoplasmic membrane. So what it does, it increases the permeability, the leakage of ions, and ultimately cell death. It can also produce a lot of reactive oxygen species causing cellular damage. So what is one species which is notoriously associated with amphotericin B intrinsic resistance? It is Aspergillus terreus, right? So here on studying this, what they came to know is, so one of the mechanisms is reactive oxygen species, right? So the molecular chaperones of this Aspergillus terreus are modified in such a way that they are able to counteract this reactive oxygen species by producing a lot of enzyme catalase and superoxide dismutase. So the superoxide dismutase and catalase will take care of the free radicals, the reactive oxygen species which has been formed against our Aspergillus species. So this influences the cellular redox homeostasis, thereby the fungal cell is protected. So most of these Aspergillus terreus species have an MIC of more than 2 mg per liter. So Aspergillus terreus, you don't use amphotericin B. In a recent study of 27,000 isolates of Aspergillus, they found out in susceptibility testing to amphotericin B, they found out that 15% of strains are resistant to flavus, 5.2% of strains resistant to niger, and 2% of strains resistant to Aspergillus fumigatus. Some other species with increased MICs to amphotericin B are your cryptic species like Aspergillus ustus and Aspergillus lentulus. So coming to another important drug and a drug resistance pattern is azoles and your Aspergillus. So how do azoles act? So the mechanism of azoles is that they inhibit your 14 alpha demethylase enzyme. To be more precise, your CYP-P450 lanosterol 14 alpha demethylase enzyme, which is involved in the biosynthesis of your ergosterol. This enzyme is coded by CYP51A and CYP51B, your CYP genes. So how does resistance occur here in azoles? So azoles form an important part of the armamentarium to treat Aspergillus species. So voriconazole are all important drugs. So how resistance happens here? One is mutation in the sterol demethylase gene CYP51A. This reduces the affinity between the azole drug and the target. Next is overexpression of your CYP51A, so that in this case, more azoles are required to inhibit the organism. Third one is increased efflux bounce. So here a few important examples of azole species resistance, cryptic azoles. Intrinsic resistance here is Aspergillus callido-ustus, again belonging to the ustus section. It exhibits mutation in the M220V region. Here again, it is due to a point mutation in CYP51A. So here you are able to see CYP51A, CYP51B, CYP51C. What are they? They are all paralogs. So what is a paralog? So in two segments of DNA can have shared ancestry. They are called homologs. A homolog can become an ortholog when it undergoes gene speciation. It can become a paralog when the genes are separated by gene duplication. So this Aspergilli, they can have duplications of the CYP51 as CYP-A, CYP-B, and CYP-C. So if one doesn't act, the other takes over. So with the use of these paralogs, they are able to exhibit resistance in several species, and that is the reason for this increasing azole resistance. So here, this is a good article, a Colombian study. Here you are able to see the list of Aspergillus species which are resistant to voriconazole. I have highlighted in red all these species resistant to voriconazole. You're also able to see some species which are resistant to amphotericin B as well. Here we'll see about voriconazole in special. You're able to see your section fumigatae, flavi, and terrii. In fumigatae, you're able to see lentulus and viridin nutans. You're able to see pseudo fishery, fumigati affinis, and novo fumigatis. Yes, these are all tongue twisters. Please bear with me. And see here in the Ustai section, this Ustas section is notoriously known for its antifungal resistance. It has 4 members in it, which shows resistance to voriconazole, callido-ustus, insuteus, pseudo-efflectus, and KBI. So I'd like you all to go through this Colombian consortium article. It's a very good article. It gives us rationale as to why to treat a specific cryptic species with a specific antifungal agent. And if required, some cases, even for synergistic effect, we have to add another antifungal agent as well. So I've come up with this mnemonic for Aspergillus species with intrinsic resistance to voriconazole, because all of it are tongue twisters. So left ventricle function is normal for people who are caring, inclusive, kind, and patient. So this is the activity of azoles against various medically important fungi. This is from one of the febrile podcasts. This is again a list of your antifungal agents in various fungal species showing resistance, which can be intrinsic, can be acquired. Coming to echinocandins are not frequently used for treatment. They are only used with respect to synergy. They inhibit the glucan synthase enzyme for the synthesis of 1,3 beta D glucan. Why they are not used for regular treatment is because they're fungistatic to Aspergillus. They're only used in combination with azoles and amphotericin B. So the take-home message is proper cryptic species identification is required. Only then you will be able to have an idea of the drug resistance profile in Aspergillus species. Aspergillus AFST testing is paramount, and we also have to look into various molecular targets for this individual cryptic species identification. Thank you. Thank you for this opportunity, ma'am. I'd like to thank my faculty from AIIMS Jodhpur and PhD Hospital for supporting me with this presentation. Uh, I'd like the listeners to also download this PDF from the Adelaide University Mycology website. It's a beautiful manual for identification of Aspergillus species. Most of the images, in addition to Laron and David Ellis, were taken from this manual. Thank you.
Thank you, Dr. Nikhil. I think a lot of our listeners who are clinical microbiologists would have benefited from this. And definitely it's an eye-opener for the other specialities, including ID, critical care, pulmonary medicine, that there is so much intricacies in speciating. So many of us, many of the time will be like, why, oh, it's just sufficient if we can identify Aspergillus species and put them on voriconazole. But yes, as you have rightly pointed out, there are intricacies in the species and in the subspecies. And definitely a lot of names are tongue twisters. So I think there are no current questions regarding the same. But I think there was one question on why peptase and dialysis affects the galactomannan test. So basically, piperacillin is derived from the fungi Aspergillus, one of the Aspergillus. So that is why you will get cross reaction for the galactomannan. And dialysis patient multifactorial basically. So there is a cellulose membrane. Some of them will be coated with the galactomannan like peptides, and these patients will undergo the dialysis water, etc., can be contaminated with the Aspergillus or the other spores. And then also these patients will be undergoing multiple FFP transfusion, albumin, etc. So all these again can contribute for the false positivity. So with that, we thank you, Dr. Nikhil, once again for your making time for this presentation. With that, we'll move to the next
Thank you, ma'am.
presenter. I invite Dr. Kriti Vaisi. So basically, she is assistant professor in pulmonary medicine in Advanced Center for Treatment, Research and Education in Cancer at Tata Memorial Center, Navi Mumbai. She is a dear friend of mine, and we are here to debust or learn more about early diagnosis and management of allergic bronchopulmonary aspergillosis. So over to you, Dr. Kriti.
Thank you so much, Akshata, for having me here. It's always a pleasure to be a part of your webinar series, and in particular this one on Aspergillosis Day. Let me try sharing my screen. Is my screen visible?
Yes, yes. You can
Great.
put it on slideshow.
Okay.
Yeah. Yes, perfect.
Yeah, without further ado, let me start off with my topic for today, which is early recognition and management of ABPA. I'll be discussing the definition, touching upon the etiopathogenesis, and going further in detail to the early diagnosis as to when to suspect ABPA, how to investigate the diagnostic criteria, stages of ABPA, and treatment of ABPA. Let us start off with the definition. What exactly is ABPA? ABPA stands for allergic bronchopulmonary aspergillosis. It is a complex hypersensitivity reaction in response to the colonization of airways with Aspergillus species, and most commonly it is Aspergillus fumigatus. It is usually seen in the 5th or 6th decade of life. It is also common in children, but it is not restricted exactly to this age group. As per studies of up to 2 to 6% of patients with asthma have ABPA, some report a incidence as high as 28%. 2 to 15% of patients with cystic fibrosis also have ABPA. And then the other predisposing, the groups that are predisposed to ABPA are COPD, that is chronic obstructive pulmonary disease, and patients with bronchiectasis. Why are these patients predisposed to ABPA? What happens in the rest of the population? Because Aspergillus, as we know, is a ubiquitous fungus, but not all patients develop ABPA. In an immunocompetent person, once the person inhales spores, there is clearance of the fungus by the mucociliary clearance, and there is phagocytosis of conidia by macrophages. This is how Aspergillus is usually cleared out. Now coming to immunocompromised or atopic individuals, there is imbalance in the host immune system, and this triggers off a Th2 mediated inflammation, and it also triggers the innate lymphoid cells, B cells, and T cells, thus causing a chronic inflammatory response leading to a tissue injury. As the IgA mediated response starts and is triggered, there is mast cell degranulation, which causes bronchoconstriction, bronchiectasis, and recurrent airway inflammation. Also, as the interleukins are released, it also causes the IL-5 in particular causes eosinophilic degranulation, which leads to excessive mucin production, airway mucus plugging. And there are some things that are formed, which is eosinophilic extracellular traps, EET. And this is mainly responsible for mucus plugging, which is pathognomic of ABPA. How does a patient with ABPA present? Commonly, the person presents with symptoms of wheeze, constitutional symptoms such as fever, malaise, weight loss, reduced appetite, and some of these could be non-specific symptoms. The most common is a difficult to treat asthma, that is, a patient is presenting with symptoms of classic asthma, but which is difficult to treat. The patient also may have symptoms of hemoptysis, which is because of bronchiectasis, which basically is caused by ABPA. If the person also has a concomitant allergic Aspergillus rhinosinusitis, the patient may also have nasal congestion, nasal obstruction, increased sinus pressure, thick, dark-colored nasal discharge. And what would we see on examination? If the patient is an exacerbation, we'll be coming to the stages of ABPA later. So if the patient is an exacerbation, the patient may have tachypnea. There may be clubbing, which is because of bronchiectasis basically. And on auscultation, there may be wheeze because of obstructive airway disease, or crackles or crepitations because of bronchiectasis. How do we investigate? Now we have seen a person and we suspect ABPA in him. How do we go forward? A complete blood count is done, and in a patient with ABPA, there would be peripheral eosinophilia of more than 500 units, and there are different diagnostic criteria have different cutoff, but these are the most commonly used cutoffs. An elevated serum IgE of more than 1000 units per ml, an elevated Aspergillus specific IgE, and this is the most important criteria. If at all an Aspergillus specific IgE is not available, an Aspergillus skin test may be done, which is positive. And amongst the Aspergillus skin tests, an intradermal is better than a skin prick test. Chest X-ray and HRCT thorax, that is a high resolution CT thorax. I'll be coming to this in further slides to discuss in detail about the features on radial imaging which are suggestive of ABPA. A sputum or a BAL, that is bronchoalveolar lavage, fungal culture showing the growth of Aspergillus fumigatus and on groth's appearance being brown in nature. A spirometry done would show most commonly an obstructive, if not a mixed pattern of defect. Let us come to X-ray. X-ray, we have studied right from MBBS that it can show a finger in glove appearance. Why is this finger in glove appearance seen? Here I have pointed arrows. All these is because of mucus plugging in the bronchi. And as the mucus, there is mucus plugging in the bronchi, it gives a appearance of a finger in glove. There could be bilateral fleeting opacities. That is, one visit the patient comes, there are bilateral opacities on chest X-ray. Next visit, they may not be there or they may be seen elsewhere. And there may be features of bronchiectasis. On HRCT thorax, that is high resolution CT thorax, which has to be done in patients suspected with ABPA, there is central bronchiectasis. What exactly is central? That is, bronchiectasis is seen in the medial half or the medial 2/3. This is called a central bronchiectasis, and there could be high attenuated mucus. What exactly is high attenuated mucus? This means that the mucus has a Hounsfield unit of around 70. That is how it is measured on radiology. We can see it could be a 70 HU density, or it could be, if we want to compare with a different structure, it is of the same density as a paraspinal skeletal muscle. And this feature, as per most criteria, is a pathognomic feature of ABPA on radiology. There are other non-specific features or signs like tram track appearance, cluster of grapes appearance, string of pearls appearance. Basically, all these are signs that describe bronchiectasis. There could be central lobular nodules with or without pretrine blood appearance. Again, this could be in other infections as well, even tuberculosis, which is more common in India than ABPA. And there could be mosaic attenuation. And why is there mosaic attenuation? It could be seen in obstructive airway disease, which again is seen in ABPA. A video bronchoscopy, if it is done, could reveal mucus plugs. Here you can see the white lesion that you can see. It's not, it can be a mimicker of malignancy of fungal colonization. This also could be mucus plugging. Let us now come to the diagnostic criteria. There are various diagnostic criteria in ABPA. There is Isham criteria, there is Rosenberg-Patterson criteria, there is Asuna criteria, and amongst the various criteria, I have just restricted to one because most of the criteria have their main framework is quite similar. So it would be just confusing to put all the criteria one by one. So I have stuck to Isham, and there is no particular reason to choose this, but it is the most recent criteria that has been updated, and this is after a this is a well-reviewed article. So what is the essential component? Mainly is the presence of a predisposing condition. It could be asthma, it could be COPD, it could be cystic fibrosis. Then coming to Aspergillus fumigatus specific IG, which should be more than 0.35, and a serum total of total IG more than 500 international units per ml. And if at all Aspergillus fumigatus IG is not available, a positive type 1 skin test is acceptable only when this is not available. And a serum IG less than 500 may be acceptable if all the other criteria are fulfilled. In the other components, any two of these components have to be positive. That is a positive IgG against Aspergillus fumigatus, which is the cutoff is different for different countries, and it is has to be more than 27 in India. A blood eosinophil count more than 500, that is peripheral eosinophilia. Expectoration of brown clumps, mucus plugs is also acceptable. On HRCT thorax, there could be features of ABPA, that is bronchiectasis, mucus plugging, high attenuated mucus, or fleeting opacities on chest X-ray. Again, stressing on high attenuated mucus, which is pathognomic of ABPA and confirms ABPA even if all the other criteria are negative. Let us now move on to the stages of ABPA. First would be an acute ABPA. That means in a previously undiagnosed patient, we all don't have a diagnosis of ABPA previously, and the on suspicion, we have got all the investigations done and the patient fits into the diagnostic criteria previously discussed. So this would be acute ABPA. The next stage is exacerbation. In a diagnosed patient with ABPA, if there is a sustained, that is more than 14 days of clinical worsening or radiological worsening, and an increase in serum IgA of more than 50%, and what is the baseline recorded, that has to be very important, because every stage criteria is based on the previous last recorded baseline serum IgA. So there has to be more than 50% increase as compared to the last recorded IgE during clinical stability. Very important is the exclusion of all the other causes of worsening. As you know that this is a ABPA is there in patients with already asthma, COPD, cystic fibrosis, etc. So an infective exacerbation or the obstructive airway exacerbation itself has to be ruled out to call it an ABPA exacerbation. Next, coming to response, there has to be symptomatic improvement, again, at least 50% after 8 weeks of treatment, and a major radiological improvement. So there is symptoms, clinical as well as radiological improvement, and a decline in serum total IgA by at least 20% after 8 weeks of treatment. So this is also tells you your follow-up dates. So if at all the patient cannot come very frequently, 8 weeks is the minimum follow-up period that has to be kept. What is when does the patient go into remission? If there is a sustained clinico-radiological improvement, that is, you have got a response and this is sustained for at least 6 months. The patient is off glucocorticoids, or if the patient has already been on long-term antifungals or biological agents, it will still be counted as a remission, but the patient has to be off glucocorticoids. There has to be lack of serum IgE of more than 20% from the last recorded IgE during stable condition. What is treatment-dependent ABPA? 2 or more consecutive ABPA exacerbation within 6 months of stopping, within 3 months of stopping glucocorticoids, and there is worsening of respiratory symptoms and worsening of radiology also, increasing serum IgE by 50% after 4 weeks of stopping or tapering steroids on 2 separate occasions. Last would be an advanced ABPA, which has extensive bronchiectasis, fibrosis due to ABPA, and there could be other fungal. There's one more entity called ABPM, which is other than caused due to fungal antigens other than Aspergillus. And along with this radiological findings or clinical findings of extensive bronchiectasis, there is cor pulmonale or chronic type 2 respiratory failure that would constitute an advanced ABPA. Let me just go through few entities, few types of ABPA, and this is what I mentioned, ABPM. If the antigen is other than Aspergillus fumigatus, that is Aspergillus fumigatus specific IgE is negative, but we do have predisposing factors. We have other factors all fitting into ABPA criteria, like a more than IgE, serum IgE elevated, there is peripheral eosinophilia, there is radiological criteria, but a Aspergillus fumigatus specific IgE is negative. And there is a non-Aspergillus species of fungus isolated, then it would be a ABPM, that is allergic bronchopulmonary mycosis. If a Aspergillus fumigatus specific IgE is positive and a serum IgE is elevated, there is peripheral blood eosinophilia, then we look at the HRCT sign. If the HRCT is completely normal, that is no bronchiectasis, with the rest of the criteria being satisfied, then it would be ABPA-S. That means there is only fungal sensitization with an ABPA, but there is no bronchiectasis. If there is bronchiectasis, it's B stands for bronchiectasis, so ABPA-B. ABPA MP would be ABPA with mucus plugging. HAM would be ABPA HEM, that is high attenuated mucus. And fibrosis, ABPA chronic pulmonary fibrosis. If a patient has asthma and you have a difficult to treat asthma, how exactly do you diagnose ABPA in them? So first, this asthmatic would be screened for Aspergillus fumigatus specific antigen. If it is negative, then ABPA is essentially excluded. In appropriate patients, we can investigate for ABPM if the other criteria and is satisfied and some other non-Aspergillus species isolated. If the screening for Aspergillus fumigatus IG is positive, then we go to serum IgE. If the total IgE is less than 1000 and the asthma of the patient is controlled, then it is just asthma with a Aspergillus sensitization. If the asthma is uncontrolled, then it is an entity called SAFS, that is severe asthma with fungal sensitization. In both these cases, the total IgE is lesser than 1000. If the Aspergillus specific IgE is positive, total IgE is also positive, and we have peripheral eosinophilia along with HRCT findings. So we have already discussed the diagnostic criteria for ABPA. Then we come to the diagnosis of the same. Let us now proceed to treatment. The most commonly used agent, unless and until contraindicated, till now, so far, the most commonly used has been glucocorticoids. That is prednisolone, methylprednisolone, deflazacort are common are the steroids available. Prednisolone and methylprednisolone are the commonly used one. Earlier, we used to have two regimens, medium dose and a high dose. And as per studies, even the medium dose starting at 0.5 mg per kg has to be shown non-inferior to the higher dosing. So to reduce the adverse effects of glucocorticoids, we are preferring the medium dose itself, that is start off with 0.5 mg per kg body weight. Either there are two regimens which can be followed, 0.5 mg per kg body weight for 2 weeks and then followed by 0.5 mg per kg body weight alternately, and then slowly taper 5 mg every 2 weeks and discontinue over 3 to 5 months. It can also be 0.5, 0.25, 0.125 per day for 4 weeks each, and then taper again by 5 mg every 2 weeks. So both these in both these conditions, we will taper the steroids over 3 to 5 months. Again, methylprednisolone, the dosing will be the equivalent of the prednisolone doses. So 0.4 mg followed by 0.2, 0.1 for 4 weeks, and then taper by 4 mg per kg body weight till discontinuation. All this to be continued be completed by 3 to 5 months or 4 months. Deflazacort dose would be 0.75 mg per kg body weight for 4 weeks and then decrease by half every 4 weeks, then taper to complete 4 months. Adverse events, effects of steroids, as we all know, in patients, especially with diabetes, we would prefer a steroid sparing agent because this can cause hyperglycemia, predispose the patient to other infections, cause all these characteristic steroids induced adverse effects like hirsutism, acne, osteoporosis, hypertension, Cushingoid habitus, weight gain, psychosis, depression, cataracts, gastritis. So already if the patient has one more risk factor for which would lead to adverse effect of steroids, then it is better to use a steroid sparing agent. And now we know that itraconazole or voriconazole are non-inferior to steroids for ABPA treatment. How do we give itraconazole? I think in the previous talks, we have, in the first case discussion especially, we have seen that a patient with extensive voriconazole toxicity, and the same with all azole. So itraconazole we can start with 400 mg per kg body weight in two divided doses, that is 200 mg BD for 4 months, and it should be it's better to be administered with meals to improve absorption. What has to be monitored? LFT ECG would have to be monitored because known side effects are hepatotoxicity, nausea, vomiting, gastritis, heart failure, palpitations. All these can be caused. So usually we call the patient for follow-up after starting itraconazole at least after 1 week with an ECG and LFT. And if the patient has just symptoms of gastritis without any hepatotoxicity, the drug can be continued with treatment of gastritis. TDM has to be done to see that itraconazole levels are attained. And if the patient has clinically improved, has no toxicities, then TDM is not routinely done in most patients, at least at our center. We also have other alternatives like voriconazole. Again, voriconazole is also given 400 mg in 2 divided doses for 4 months. Side effects are similar, but again, there are voriconazole, as we have seen, is relatively less tolerated as compared to itraconazole. Side effects again being headache, hallucinations, anxiety, insomnia, photosensitivity, liver toxicity, prolonged QT interval. Again, for voriconazole also we can do TDM. Posaconazole, especially if both other azoles are not tolerated, posaconazole can be used. Isoconazole is another alternative. Nebulized amphotericin and glycoamphotericin have been described as alternatives, but these are not commonly used. They are very expensive agents, and usually between steroids and the other azoles, we are able to manage most of the patients, and at least in none of the cases that I have seen, we have had to resort to nebulized amphotericin B for a routine ABPA treatment. We also have biological agents, and these have extensively been studied in treatment of asthma. And because we have a Ig-mediated inflammation in ABPA, these are other steroid-sparing alternatives that are there for ABPA. Again, these are very expensive. Omalizumab, all these are biological agents that are targeting a particular interleukin or a stage in the Ig-mediated cascade. We have omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab. I'll go to the next slide, which will describe better as to what agent is, which stage is being targeted by the particular agent. Here you can see the inflammatory cascade that is triggered off by aspergillosis, and why we have tried to use these agents. Omalizumab it's an anti-Ig antibody, which is we also use in patients with atopy and severe asthma. This is a steroid-sparing agent that can be used and has found to reduce asthma exacerbation and has found to have remission in ABP as well. Then we have IL-4 antagonist, that is dupilumab, IL-5 targeting agent benralizumab. But all these are expensive agents, so routinely before trying azoles or before trying steroids, and if there is no contraindication to these, we would not resort to these biologics. Now coming to my penultimate slide, this is my take-home message. So 10 commandments you can stay. When do we suspect ABPA? We have to suspect ABPA in a patient presenting with symptoms of asthma, with it could be even COPD or cystic fibrosis, with fleeting opacities on chest X-ray, bronchiectasis, eosinophilia, and elevated IgE. If the HRCT feature of HAM is seen, it is pathognomic of ABPA. High-dose inhaled steroids do not achieve symptom control or reduce ABPA exacerbations, because for asthma, routinely we use inhaled corticosteroids along with bronchodilators like LAMA, like long-acting beta-2 agonists, but these are not the primary therapy for acute ABPA. Oral glucocorticoids are the most rapidly acting treatment for acute ABPA, and between itraconazole and voriconazole, they have similar efficacy as systemic glucocorticoids in acute ABPA with fewer adverse events. Oral itraconazole has steroid-sparing action in treatment-dependent ABPA also. Posaconazole may be given and it achieves clinical remission in ABPA patients who are not tolerant to other azoles. Omalizumab reduces asthma exacerbations, as I've previously discussed, and has steroid-sparing action in treatment-dependent ABPA. Other biologic agents mepoli, benralizumab, dupilumab, tezepelumab, all these reduce asthma agents and have a steroid-sparing action in treatment-dependent ABPA. Nebulized amphotericin B may reduce ABPA exacerbations and increased the first time to the first ABPA exacerbation. That means you have treated ABPA and the patient has come back with exacerbation. That time may be reduced when it is used as maintenance therapy in stable ABPA. With this, I come to the end of my discussion. Thank you. If there are any questions, I'd be happy to take them.
Thank you, Dr. Kriti. I mean, lot of confusion and queries regarding ABP has been addressed too. And questions, I personally have few questions.
Sure.
So basically, like in a case who has been diagnosed as ABPA, do you think would you start only steroid or would you give along with an antifungal? I just want to know your approach.
Yeah, our approach basically because I work, in a cancer center, and many of these patients are started on will eventually go on immunosuppressions. So in such category of patients, either who go for immunosuppression, who already have diabetes or any predisposed condition that already their low tolerance to steroids may be there. Then in these patients, upfront itraconazole is would be a preferred agent and the agent of choice. And itraconazole, as we have seen that it is a little better tolerated than voriconazole. So anti fungal agents would be my drug of choice in these agents. Otherwise, if it is a relatively younger patient, no other comorbidities, might tolerate steroids after discussing with the patient, then prednisolone or a methylprednisolone may be used. But both these are found to have not inferior to each other, be it glucocorticoids or antifungals. So if there is no contraindication to the to azoles, then for me, my personal choice, and again because they are well tolerated and have reduced side effects as compared to steroids, azoles would be the drug of choice.
Okay. So, like leading to the same question. So, obviously, you deal with more immunocompromised patients. So, are you like, is it possible for ABPA to turn into invasive aspergillosis? Is it because, as I've seen, based on pathology, it is the fungal sensitization rather than the fungus per se. So, do you think could it transform into IPA?
Yeah, this I think temporal relation of an ABPA turning into invasive aspergillosis, it might be difficult to prove in patients, because we do not know that this particular patient had ABPA, it was untreated, and then we'll need previous radiology, previous history, previous investigations of serum, IG, eosinophils before and then the patient going in for immunosuppression. So if we already know that the patient has aspergillosis, then the patient would be treated, put on antifungals before he or she goes for immunosuppression. But definitely it is possible that an ABPA patient, if untreated and goes for immunosuppression, definitely the patient may end up with the invasive aspergillosis too.
Yeah. And last question. So, have you used Suba itraconazole? So, it's supposed to achieve better levels of itraconazole rather than the usual conventional.
Yeah, I had mentioned it in my slide as well, but no, I have no experience with using it, and commonly used agents, at least by me, would be itraconazole and voriconazole. I have not used the other agents when it comes
Okay.
to antifungals.
So, I think there's one more last question. What is the scenario? What is the current scenario or percentage of aspergillosis caused by non-fumigators? Okay, I think it is not relevant to your talk. Yeah. Thank you. Thank you, Dr. Kriti, for addressing all the queries regarding ABPA. And with that, we'll move to the next talk.
Thanks, everyone. Thank you, Dr. Akshatha.
Yeah. So next we have Dr. Yash Katot, who is a DMID, completed DMID and currently working as senior resident in AIMS Jodhpur. So he's here to debunk the various like misdiagnosis of chronic pulmonary aspergillosis, especially in a country like India. So what are you, Dr. Yash?
Okay. So am I audible? Are my slides visible?
Slides are not visible. Could you share? Okay.
Just a minute. Is it visible now?
No, Dr. Yash.
Just a minute. Okay. So
Yes,
now
it's
is it
visible
visible?
now. Yes, yes. Can
Okay.
put it in slideshow.
Yeah.
Perfect.
So thank you, Dr. Akshata, for this opportunity, and happy World Aspergillosis Day to everyone. After so many talks regarding invasive form and allergic form of pulmonary aspergillosis, let me talk something about chronic pulmonary aspergillosis. I think it is, in my opinion, it is one of the most trickiest condition to diagnose, and that is it. Whatever the difficult part in CPA is, it's the diagnostic part. So I will be talking about the diagnostic challenge. So I will just start with this question come statement. When should we suspect CPA upfront? So it's a rhetorical question. The answer is never. You should never expect or suspect CPA upfront. The suspicion of CPA should be made ideally when other more plausible causes are ruled out. Even when there is a history of pulmonary TB, which is the most common predisposing condition, even if you have all the records available, patient is saying that he was completely treated and there was a resolved infection, you should actually go back to the documentation for the appropriateness of the therapy, as well as you should always rule out the reactivation or development of the other more possible conditions before considering the diagnosis of CPA. Yes, it should always be there in your back of mind, but the first thing to consider, and one of the most important diagnostic challenge which I consider, is to rule out other conditions, more possible conditions. So these are the most common risk factors for pulmonary chronic pulmonary aspergillosis. So almost 85% of the cases of chronic pulmonary aspergillosis had history of TB. There was one study conducted on 126 patients. Almost 40% of the cases actually had some or the other form of mycobacterial infection, be it TB or NTM. Now, you people were discussing with Dr. Kriti, and you were discussing whether to give uh, itraconazole therapy in ABPA patient. You can see here ABP is also one of the risk factor for chronic pulmonary aspergillosis. So all the guidelines just consider steroid as a first line therapy for ABPA, but you see that ABPA actually causes the structural distortion of the lungs, and ABPA can actually progress to chronic pulmonary aspergillosis. At that time, I think rather than going into invasive aspergillosis, chronic pulmonary aspergillosis should be kept in mind when you are dealing with non-responding APPA. That is very important, I think. So there is a risk factor that if TB had caused some sort of cavitation in your lungs, in your patient's lungs, so if the cavity size is more than 2 centimeter, there is 15 to 20% chance that it will go on developing chronic pulmonary aspergillosis. So this study was done in 2007. Almost 7.7 million cases who had TB, 372,000 developed CPA. So the risk is not very high, but it is still substantial, if you ask me. And it depends upon the geographical variation. In developed countries, it is just less than 1 case per 1 lakh, while in African countries like Congo and Nigeria, the rate was as high as 42.9 per 1 lakh. India was lying in between 23.1 case per 1 lakh population of cases who had TB. It's not about the general cases. It is not just that there was less prevalence because of the climatic conditions for invasive or fungal pathogens in the environment. It is also, I think, more related to earlier diagnosis of TB before it could cause any structural damage to the lung. So countries where diagnosis of TB is delayed because of multiple of the reasons, uh, if the TB is diagnosed at a stage where already the structural damage to the lung has happened, the CPA is more likely. I'll just go with the case scenario. Here, a 38-year-old alcoholic male with past history of TB, probably cavitation, underwent a chest X-ray for medical clearance for some job. There was a X-ray done. Here is the X-ray, and you can see some cavitatory lesion in the right upper lobe. CT was suggestive of aspergilloma. I just want to ask you people, whoever is listening, what should be the line of management? Will you start itraconazole and continue it for prolonged period of time, which is actually in fact the therapy of chronic pulmonary aspergillosis? Would you get some serological diagnostics before considering the management? And since it is a simple aspergilloma, you will not warrant the treatment. Or fourth option is patient need regular follow-up. Just keep the option in your mind and we'll discuss. You'll get the answer, I hope, in the end of the presentation. To understand the diagnostic challenge, first we have to little bit be oriented about the pathophysiology of CPA. We must understand that the primary driver of the disease in CPA is immune response to the fungal pathogen rather than the true invasion of the fungus of the airway by fungus. So interplay between the host factors, the immune system of the host and the fungal pathogens, fungal hyphae is actually the driving factor for the development of cavitation and lung lesion. This is very important that invasion of fungus is not self is a major contributor. It has a diagnostic implication. That's why I have put a slide over here. Just coming to the clinical spectrum of CPA, there are five varieties of CPA. I personally, in my own understanding, I consider only four types of CPA. That is aspergilloma, aspergillus nodule, chronic cavitatory form of pulmonary aspergillosis, and chronic fibrosing pulmonary aspergillosis. These four are basically chronic pulmonary aspergillosis, in which patient actually have history of more than 3 months. The disease is quite kind of indolent and onset. And first two, aspergillomas and aspergillus nodule, actually do not cause the invasion or even the expansion of the lung lesion. They are like necrosis happening within a confined area, while chronic cavitatory and fibrosing form are actually expansile form of the chronic pulmonary aspergillosis. In my opinion, though most of the guidelines says that subacute invasive pulmonary aspergillosis is a form of chronic pulmonary aspergillosis, I consider it to be a different entity altogether. The diagnosis is actually the patient may have subacute onset less than of 3 months and they are more sick and have more amount of immunosuppression, subtle, not subtle, but there is obvious sort of immunosuppression, not as much as severe in invasive aspergillosis that it was discussed in first presentation, but some sort of subtle level of immunosuppression. So I will not be discussing this part of CPA because it is a kind of emergency for me. Even if a patient is having subacute invasive pulmonary aspergillosis, I will treat it with a kind of emergency in my mind. So the most common clinical feature which should be present for more than 3 months to consider the diagnosis of CPA. The first one is asymptomatic. As I told you, the first two form of the chronic pulmonary aspergillosis, that is aspergillus nodule and aspergilloma, simple aspergilloma, are most of the patients are actually asymptomatic, and if the symptoms are present, they are very, very minimal. Some like bouts of cough, sometime hemoptysis. The other common presentations are cough, sputum, hemoptysis, dyspnea, anorexia, weight loss, and night sweats. So these are the classical presentation of chronic cavitatory form of pulmonary aspergillosis and chronic fibrosing pulmonary aspergillosis. Fever is extensively rare, and the thing is, if fever is present in your case, you must consider that the patient might be having some sort of invasion of the airway or of the blood vessels, maybe airway invasive or angio-invasive form of aspergillosis may be underlying the case. You should also rule out the immunosuppression in the case, and maybe some alternative diagnosis or super added bacterial infection should be considered. So if fever is there, you should just this thing should click in your mind. Dr. Akshata, is the diagnostic part, the slide is visible? Can you tell me?
No, it's a white slide. No, there's nothing.
Just a minute, there is some confusion. Okay. Now?
Yeah. Yeah, now
Yes.
it's visible.
Okay. So, coming to the diagnostic part of the CPA, as I told you, 4 types of CPA, and most of you might know this, that 3 criteria are needed. That is clinical criteria, symptoms which I have explained earlier for more than 3 months, and laboratory criteria, which basically involves serology, the precipitants IgG for Aspergillus, which should be positive. There are several guidelines which says the cutoff also, but I think it is just positive or negative depending upon the test you are using, and radiological criteria, suggesting some sort of expansile cavities or fibrosis, lung distortion in some form. If all these 3 criteria are there and you have ruled out other possible causes, then the diagnosis of CPA is likely. But these 3 criteria are in general uh, is definitive of chronic cavitatory form of pulmonary aspergillosis. While other form of chronic fibrosing pulmonary aspergillosis, while aspergillus nodule and aspergillus, a simple aspergilloma, might not fit into this kind of criteria. I will explain to you this later on. So, just for your understanding, the diagnosis of CPA should be understood in terms of dissemination in time and space based on the follow-up, like we do it for multiple sclerosis. If you follow up the case, the cavity or the lung lesion are increasing in the space of lung and over a period of time, then the CPA is the likely diagnosis. Just not on the first day of the patient visiting you, not much of a symptoms. On that very day, you can't make the diagnosis. You have to follow up the case. I just want to make clear here that if your patient is sick enough, if he has some sort of severe symptoms, or he is likely to have severe symptoms because of his condition, then instead of CPA, subacute invasive aspergillosis should be considered in your mind, the diagnosis of subacute invasive pulmonary aspergillosis, and treatment should be started upfront. You don't have to wait. You have to decide on case-to-case basis. So for each and every one, for aspergilloma, simple aspergilloma, if you say, the criteria will include minimal symptoms. It may be no symptoms at all, and just a radiography for some other cause, as we discussed in the case, is positive for the aspergilloma, and aspergillus IgG is also positive, and it should be stable over a period of 3 months. If the cavity is increasing in size, or there are multiple cavities or new cavities are forming, then it will not be called as simple aspergilloma. Rather, it will be called as chronic cavitatory pulmonary aspergillosis in that case. Similarly, for aspergillus nodule, most of the cases may have minimal symptoms or no symptoms at all, or they may be symptomatic depending upon their condition. So, radiologically, you will find a nodule, and the diagnosis is confirmed by biopsy. So, the thing is, if you are seeing a nodule, you will not be suspecting aspergillosis upfront. You will think that maybe a malignancy or some other condition, and you will get biopsy, and then you will realize that, okay, it is a form of aspergillus nodule. So again, the 3 criteria which I described for chronic cavitatory pulmonary aspergillosis might not fit here. Sometimes it is just incidentally identified. And I want to make it very clear here that if your patient is having multiple nodules and you diagnose one nodule to be aspergillus in origin, it does not imply that rest of the nodules or the rest of the lung lesions are of the aspergillus etiology. You should rule out, depending upon the clinical scenario, that multiple conditions can coexist in a same case. Talking about CCPA, it is the same thing which I have discussed earlier. And CFPA, if with the features of CCPA, over a period of time, extensive fibrosis develop in the lungs of the cases, then it is called as CFPA. Always rule out alternate cause. That is my first and last message from this slide. This is very important. So, in this sense, whatever we have discussed till now, serial radiology is the most important diagnostic parameter. And next comes the serology, which is IgG for Aspergillus fumigatus by enzyme immunoassay. That is a test available with very good sensitivity of 84.1% and specificity of 89.6%. So it is a very good test, but again, you should consider the clinical scenario. You should consider the diagnosis in the right context rather than overshooting the investigations. So this is actually kind of take home message also, that what are the challenges in the diagnosis, as it was already discussed in the opening note by Dr. Akshatha, that lack of awareness of the aspergillosis is itself is a challenge. we as a ID clinician consultants actually may overdiagnose CPA sometimes, but most of the doctor and medical fraternity is actually underdiagnosing. They think that it is TB which is relapsing, and the patient keeps on taking ATT. Sometimes they take treatment for NTM and so many things, but they do not arrive to the diagnosis of CPA. So lack of awareness is the most important challenge. And again, another thing is lack of objectivity in definitions for the spectrum of disease. As I explained earlier, there are many societies and guidelines which suggest that all three criteria are needed for all four types of CPA. But what happens if you just incidentally find out without serology, without symptoms, that a nodule is a Aspergillus nodule? So will you reject the diagnosis? The answer is no. So there is lack of objectivity in the definitions, and predisposing condition can mask the clinical features. So you keep on suspecting that, yeah, the patient might be having ongoing TB. You are not even suspecting co-associated CPA in the case. Similarly, you have to rule out the other infectious condition, which also can coexist. I explained just now. And as I explained earlier, diagnosis require follow-up over time. Limited utility of microbiological tests like cultures. So when I explained the pathophysiology, I said that lung invasion by the fungus is not the driving force. So even if you are isolating the fungus from your samples, respiratory samples, it even with the most compatible feature, it does not simply implies that patient is having CPA, because you have to prove that patient is having some sort of immune response, and that we do by the help of Aspergillus IgG. The serological test which is available is most likely, most of the time, is Aspergillus fumigatus specific IgG. So what happens if the allergic reaction, or I'm sorry, the immune reaction to the fungus is actually, the fungus is not Aspergillus fumigatus, some other form of the Aspergillus, like Aspergillus teres or flavus. This is the case in North India, Punjab region and Pakistan region, where non-fumigatus species are more common. So again, the diagnosis become dicey there. You have all the features, but you don't have the serology, and the criteria is not fulfilled, and you just disregard the diagnosis. Again, the response to a therapy cannot be monitored with some simple tests. That is another challenge. You have to follow up the patient and the symptoms, whether they are improving or not, radiology, whether they are improving or not. Sometimes radiology becomes static and patient keep on having symptoms for many other reasons. And the symptoms are subjective for the patient. So we can't actually compare whether the patient is improving or not over a period of time. Sometimes you can use the corroborative evidence, though they will not fit the diagnosis criteria, but still you can use, especially when you are not suspecting the Aspergillus fumigatus species. In that case, species identification by BAL fungal culture or BAL PCR tissue biopsy can at least give you some evidence that there is a exposure of some sort of Aspergillus in the case, and you can proceed with the treatment and try and test the patient. A BAL galactomannan, serum galactomannan can some other corroborative tests, but they are not necessary and sometimes can lead to the overdiagnosis of CPA. So coming to the proposed algorithm from whatever we have discussed now, with compatible risk factors and symptoms and radiological uh, uh, features in the case. Just a minute. Yeah. Radiological features in the case, the first thing we have to do is rule out the common etiology. And in India, it is always TB, TB, TB. When you have done all of these things, then you should think of CPA, Aspergillus IgG, then you should stand for the Aspergillus IgG by EIA. Now, here, whatever studies I have read and uh, tried to quote here, all of them have used this sort of test. Sometimes there are rapid car tests, whether the companies, the manufacturers claim that they are as good as EIA, but the studies are lacking regarding this. So if this is positive, you can go for other corroborative tests which are completely optional. You want to do it, you do, otherwise you just proceed with the treatment. If the tests are negative, then I think it's better to go for the corroborative finding if the symptoms are compatible and you are unable to make alternate diagnosis. If any of these things are positive and the diagnosis is highly likely for CPA, you should proceed with the treatment. And treatment, if the patient is responding, then most likely the diagnosis was CPA. If all these tests are also negative, then I think it's better to leave it there and think of something else. So this is how you should proceed. Rule out alternate cause and then go through the Aspergillus serology. This is my last slide. I just want to emphasize here that we all know that the treatment for CPA is prolonged itraconazole therapy because it is easily available, time tested, and cheaper for the patient. But as I told you, there are so many uh, irony in the diagnosis of CPA. What happens that patient was actually symptomatic for past 3 months, and in just last 1 month he had some sort of immunocompromised state which progressed, and the diagnosis of CPA becomes subacute invasive or invasive form of aspergillosis. So in that case, I think you should not shy off in starting IV and more aggressive therapy with voriconazole, which is uh, likely to give better results for invasive form of aspergillosis. And if your patient is also likely to be sick, you can consider IV voriconazole and even sometimes amphotericin B, because Dr. Nikhil also had explained in his presentation that there are many cryptic species or species which are actually considered to be fumigatous, and they are actually resistant to the common antifungal agents. So with this, I just conclude my presentation. I hope it was productive to everyone.
Thank you, Dr. Yash. So you didn't give the answer to the first question. So, so did you
What
treat the
was
patient or did you not treat the patient?
actually the answer was self-explanatory. I hope we have to follow the case.
Yeah, sure.
If
Thank
on
you.
follow-up, if on follow-up you find that cavity was increasing, then it is not simple aspergilloma. Just disregard simple aspergilloma, diagnosis of simple aspergilloma. Rather treat it like CCPA. And if patient has some sort of immunocompromised state, subtle or obvious, you treat it like invasive pulmonary aspergillosis. That is my understanding of the subject.
Thank you. So definitely CPA is not as straightforward as it seems. So each, like till now, we have learned that each spectrum of aspergillosis brings with it its own challenges. So you talk about Aspergillus IgG. So do you think galactomannan is of any use in CPA?
Since, yeah, as I explained, sometimes Aspergillus IgG was, most of the time it is specific to the fumigatus species. So if there is some other species which we are not aware of, maybe galactomannan, bal galactomannan can be of some help. At least you can consider diagnosis and you can test the patient with the treatment. If he is responding well and good, if not responding, then we can stop the therapy. It's always case to case basis. You and me, we have seen a lot of cases of CPA, and it is always very difficult, and it is associated with great morbidity. The patient has already suffered with his restricted lung capacities, and because of CPA, their life is like too much compromised. It is a kind of grievous situation for the families.
Thank you. Thank you, Dr. Yash.
Yeah.
So with
Thank you
that,
for the platform.
thank you. With that, we move to the last, but not the least. Definitely, all of I think one thing which was common with all the talks was their emphasis on um, the emphasis on therapeutic drug monitoring for all the antifungals. So to dwell in more deeply into this topic, we have Dr. Franklin. Just a second. So it's my pleasure to introduce Dr. Franklin. Dr. Franklin Jose is a clinical pharmacist at SRM Medical College Hospital and Research Center. So he'll be here with us to debunk the various myths about the TDM, when to do, what is the utility of TDM, and is it required. So over to you, Dr. Franklin.
Thank you, Dr. Akshatha. Thank you for this opportunity. Okay, I'll first share this slide. PowerPoint. And, Is it visible to all?
Yes, yes.
Okay. Start. And the topic which was given to me is therapeutic drug monitoring for antifungals, especially triazoles, and it is for sorry, just is it the slide changing, ma'am?
No, you try with the mouse or you just close the screen and reshare.
Oh, just give.
Not
Okay.
happening. Yeah.
Yes, yes, fine. And today we are going to see why and when and how we can do the TDM. First, let me start with the introduction. What is TDM? TDM is nothing but to measure the drug concentration in the bloodstream of a patient, and which it is actually kind of personalized today in a modern medicine. It is like a personalized medicine kind of therapy, and the goal is to optimize the therapy to achieve the therapeutic range and to avoid the toxicity or side effects of the drugs. And mm, why do we need TDM? TDM is actually needed mostly for the narrow therapeutic drugs, not just for antifungals. It is also needed for the drugs like immunosuppressants and antiepileptics like phenytoin, which are also narrow therapeutic drugs, which with the slight dose increases might cause severe drug toxicities. And another thing is like high interpatient variability in pharmacokinetics, like children's which have which mostly be a fast metabolizers or critically ill patients or obese patients, they require a TDM to achieve the therapeutic. Sorry, not to achieve, to make sure the whether the patient has achieved the therapeutic range with the usual dose which guidelines are recommending. And drug-drug interactions. Drug interactions are a major role in antifungals because most of the triazoles will metabolize by CYP3A4 enzyme, which is responsible for the metabolism of many drugs. For example, rifampicin and even like drug-drug interactions, we can say. Proton pump inhibitors, H2 blockers, these kind of drugs will also triazoles mainly posaconazole will be more absorbed in acidic state. So if the patient is on any PPA or H2 blockers, which eventually decrease the concentration of posaconazole in the body, and the patient might not improve clinically if any drug interaction happens. And to prevent the toxicity and to prevent the treatment failure. These are the four main things we consider for TDM. And monitoring the specific populations, as we said above itself, like critically ill patients, like the patients who are on immunosuppressants or immunocompromised patients, and who are CKD or hepatic failure patients, because the triazoles are metabolized in liver. When if a patient had any liver injury or anything, the dose should be adjusted. And why TDM for triazoles? And because triazoles are a narrow therapeutic drugs, as we seen before, most of the narrow therapeutic drugs needed TDM to achieve the therapeutic concentration. So, and most of the triazoles are narrow therapeutic drugs, so we need to do TDM for those. And here I've mentioned the voriconazole. The voriconazole actual therapeutic range is around 1 to 3 microgram per ml. And the toxicity range is just 1 microgram more. It's 4 to 6, it will become a toxicity. It is still debatable. There are some studies and papers are suggesting that even 3 microgram per ml even produces toxicity to the patient. And isavuconazole, the therapeutic range is around 2 to 4, and the toxicity is with the next thing from 5 to 6 microgram per ml. And variable and YTDM for triazoles, the triazoles have variable absorption and metabolism. Like itraconazole and voriconazole have a very unpredictable pK, and even the fatty foods, acidic nature of the pH of the stomach, and the drugs we take, everything will make the drug absorption very unpredictable. And which follows the itraconazole and voriconazole will follow a non-linear pharmacokinetic panel, in which the drug actually if we increases dose slightly, even at least a 50 mg, the elimination will get affected. The elimination will get saturated in the non-linear pharmacokinetic. So itraconazole and voriconazole requires tedium, but not for fluconazole, because fluconazole follows a linear pharmacokinetic method. And drug concentration varies falsely, as it actually relevance to the previous point. The drug concentration varies depends on the individual's age factor, and like obesity, weight, and whether the patient is immunocompromised, whether the patient have any chronic conditions or organ failure. These conditions will vary. These conditions will decide the concentration of the drug in each individual. So that's why we need tedium. And compliance important, like long-term therapy, like voriconazole. As I said before, voriconazole follows a non-linear pharmacokinetic, so the elimination rate will be saturated. And mostly mostly antifungals, the patient will be mostly around 12 to 16 weeks of therapy. So there are more chances to develop toxicities like triazole neurotoxicity or hepatotoxicity. Even patient have experienced hallucinations or photophagia kind of adverse events. And when to check the tedium for triazoles? These are some special considerations, so we should consider tedium. Like this is drug-wise I mentioned. Like for oral posaconazole, especially for suspension, the posaconazole have an absorption of around 80 to 86%, but the absorption, even both are oral, the absorption will vary for capsule and suspension also. So because of this variability, if we are changing to if we are changing from IV to oral, or even oral capsule to suspension or something, suspension, we have to do the tedium, because the drug concentration varies unpredictably even for small changes of doses. And voriconazole and posaconazole both follows the non-linear kinetics. So because of this non-linear kinetics, it is not actually needed to DDM for voriconazole even when starting the therapy. But if we are changing the dose, or if the patient is not clinically improving or something, we have to do the tedium. And for itraconazole, and as like posaconazole, capsule and suspension differ in oral bioavailability. And first, after starting the therapy, we can do a tedium to ensure the therapeutic levels. And now after starting the therapy, it doesn't mean on the next day or not from the first dose. We have to give some time for the drug to achieve the steady state. It differs from drugs to drug. For posaconazole, many study states that from 2 to 3 days, 2 to 5 days. We actually follow, we are in our institution, we actually follow from 5 to 7 days of we'll give time for to attain the steady state to patients. And after dose adjustment, as I said earlier, dose adjustments will have a great impact in drug concentration in the body. So even a minor dose adjustments in triazoles will have a greater impact in drug concentration, which may lead to toxicity. So yeah, after a dose adjustment, it is recommended to do a tedium to confirm whether the patient has achieved the therapeutic concentration or not exceeding the therapeutic concentration. And if the patient has no clinical improvement, then we can go for a tedium to check whether whether the drug is still is in subtherapeutic levels, or we have to so that we can know whether we have to increase the dose, or how the patient is responding to the drug. and the signs of toxicity. And as earlier I said, critically ill patients like sepsis, CNS, aspergillosis patients, organ failure, these patients are highly recommended. Like the critically ill patients are highly recommended for tedium, because this we can't predict with the guidelines for these patients. Each patients will have a different metabolism, so especially in critically ill conditions or organ failure patients. And these are the some conditions which I have mentioned. The TDM is mandatorily required, like invasive fungal infections, to ensure the therapeutic levels. These are the last column is the drug of choices, which you can see all are triazoles, and prophylaxis in when high risk patients like immunocompromised or something, the prophylaxis to prevent the infection, the TDMs need to be done to the whether patient is attaining attain the therapeutic level. Actually, in prophylactic conditions, the therapeutic level is not need to be maintained. For example, like in voriconazole, the therapeutic range is around 1 to 3 microgram per ml. But for prophylaxis, the concentration can be for only 1 mg, not need to be go until 3 microgram per ml. It is if 0.5 to 1 microgram per ml of concentration is enough for a patient on prophylaxis to prevent an infection, on therapy to prevent for the prevention. And treatment failure conditions to rule out the subtherapeutic levels and toxicity, liver diseases, because as I said earlier, triazoles are mainly majorly metabolized by CYP3A4 enzymes. So if the patient have any liver dysfunction, it will affect the drug concentration, and it may lead to drug toxicity if, even in the recommended doses. So we have to adjust the doses accordingly. And obesity and pediatric patients actually require high doses than compared to adults. If an adult require an so if an adult require an oriconazole of 6 mg per kg, a pediatric patient or a child less than 40 kg of weight will require some 9 mg per kg per day. Because the pediatric patients will have a in CYP3A4 enzymes production in high state. So the pediatric will require high drug concentration. And cystic fibrosis and drug interactions, as we discussed earlier. And how to do tedium? First, I would like to start with the missions used in tedium. And these are the three most common machines which are used for tedium: high power HPLC and liquid chromatography mass spectrometry and automated immunoassay. Actually, LCMS is the liquid chromatography mass spectrometry is the gold standard, but in most of the institutions, which it was not used because of its expense, because it is very expensive and it requires specially trained technicians for LCMS specifically. And but it is very high in specificity to identify the drug concentrations compared to other two methods. But and most of the institutions, HPLC is used to find the drug concentration of triazoles. Even in our institution, we use HPLC to detect the concentration of voriconazole and posaconazole. And HPLC actually separates the drug molecules from plasma and serum, which is also high accuracy, but comparatively LCMS is much better. But HPLC also will provide a good specificity ratio. And automated immunoanalyzers are meant for tedium, but it is not currently mostly used for tedium purposes specifically. And the chemicals used in tedium, and the methanol and acetonitrile or water can be used as a solvents. And internal standard triazole antifungals, actually the triazole antifungal, the recommended guideline concentrations will be uploaded through a software to the HPLC, and the mobile phases like ammonium acetate, formic acid. These things are helpful to maintain the pH in the machine as same as in our stomach, because the pH has a very how to say, the pH has a very important role in triazole metabolism. So if the pH changes when it is outside the body, the pH changes, the drug concentration also varies. So to maintain the pH of as it is in our body, these ammonium acetate and formic acids are used to maintain the pH. And these are the things we follow to how the TDM is actually done. The blood samples will be collected. Usually, we will wait for around 5 to 7 days from starting the therapy to achieve the steady state. Even if the patient has missed the dose, the patient is on treatment for around a month, but before the patient is coming for a TDM, if the patient has missed the dose for some 2 days and he has been taking for the past 3 days also, we'll make sure that the patient to wait until to make him regularly take for at least 5 days, because otherwise the steady state won't be achieved, and we may not be sure whether the value which is showing us whether it is true or not. So we'll make sure at least 5 days the patient should be continuously on a drug which we are going to test. And the trough, and usually 2 to 5 ml of blood will be collected, and it will be sent. The trough will be collected 30 minutes. What we will do here is we will collect the trough by 1 hour before and 30 minutes before. The timing is very, very important in TDM. We cannot just simply make the patient come. Whenever the patient comes, we cannot take. The timing is very, very important. We should make sure the patient has took the medicines on the 5 to 7 days on a week. The patient is we have to counsel the patient. The patient should take the medicine on the proper time. Like if it is advised for 9 a.m., the patient should take it as for 9 a.m. and 9 p.m. properly for the 5 to 7 days. And we'll make sure the patient will be coming 1 hour before to the lab to his next dose, and we will collect the sample by 1 hour before and 30 minutes before. Usually, actually, 30 minutes before, one sample is enough to calculate the trough level. But to make sure it double confirmation, we'll take it 1 hour before and 30 minutes before the next dose. And it should be centrifuge for 1500 to 2000 RPM and for 10 to 15 minutes, so that the plasma will be separated. And the blood should be collected in a EDTA tube or a heparin tube. And it will be analyzed with the HPLC or LCMS machine. We can analyze around 15 to 20 minimum, 15 to 20 patients sample at a time, and the results will be available within some 10 to 15 minutes. And we can interpret the results with the standard therapeutic range which we have incorporated into the system, and it will show the comparison of whether it has been above the standard therapeutic range or it is low. The system it will show within some 15 minutes of running it, and the dose adjustment should be dose adjustments can be done based on the TDM results. Usually the dose adjustments will be done if the dose is less than a therapeutic range, and the next available dose will be given. For example, if the patient is taking 200 mg of voriconazole for BD or TDS, will increase the dose for 300 mg. And we can't increase the dose directly to a very high extent. The dose adjustment should be the dose should be increased or decreased slowly, because in triazoles, even a minor dose adjustments will have a great impact in drug concentration. So the dose adjustment should be made precisely, and we have to slowly increase or taper the dose slowly. And again, the test should be done on the next 2 days to see whether the patient has been achieved the state, and or else most of the patient In our setting, most of the patients are insurance patients because TDM is little expensive test. For a single test for a posaconazole, it will cost around 3,000, and it depends vary on the chemicals we use and the drugs we are checking and how many times we are collecting it. So usually it will cost around from 3,000 to 5,000 for a single test. So most of the insurance patients can afford, but if the patient is spending money from his pocket, it is not like in a hospital setting where mostly lower or middle income people are coming. It is not possible. So we can observe it once the TDM is done. We can reduce the dose and we can observe the whether the toxicity is reducing or whether the patient is clinically improving. We can confirm with it. And thank you.
Thank you, Dr. Franklin. So I have few queries. So,
Yes, sure.
you mentioned like dosing adjustment. If the patient is having very high levels, like
Yes.
I think Dr. Anjali discussed one case where it was very high, like 7.8. So how many days will it take to settle down? So when do you recommend to us to repeat the TDM and the like decrease the after decreasing the dose?
Actually, ma'am, it will take. We will make sure the patient have if the therapeutic sorry, if the drug concentration is high, we'll make sure the patient to quit the drug for 1 day or 2 day, and we will take the test whether after, because triazole half lives are very high. It is around some 36 hours or 30 hours more, definitely more than a day. So we'll make sure to if the toxic range is more high, we'll make sure the patient to discontinue the drug for some 1 or 2 days, and we will take the sample again and we will check how it has been dropped, how much after discontinuation for 2 days, how much it has been dropped. We will check, and if it is dropped more down than a therapeutic range, and we usually go with some basic sorry, if the patient is on 200 mg, I'm example for an example I'm saying, if the patient is on 200 mg, we'll then start with some 100 or 150 mg, and again we will monitor after some 3 days, 3 to 4 days, whether
Okay.
it is in the therapeutic condition. Most in our setting, mostly the patients are insurance patients, but my colleagues are many have said the patients are not willing to take test repeatedly as it is more costly. So what they do is they reduce the concentration and they'll just follow for whether the symptoms are reducing or not. They'll just we can also clinically observe by reducing the dose.
Okay. Other query is like, yes, sir, we do reduce the dose. So, and the tablet Vori is available as 200 only. So,
Yes,
like, how do you, like, 150, if the patient is requiring like around 300, do you recommend us giving 200 mg one tablet and half a tablet in the evening, or 150, 150? As I understand, it should be equally distributed. So, if a
yes,
patient based on the weight, he is requiring 300 mg,
yes.
overall 300 mg in a day,
We'll
whether
give it
to
as TDS, ma'am.
oh,
Oh, you are asking 300 mg a day. Oh yes, mostly
huh,
it will be as a TDS dose.
okay, like 100 mg TDS or
Yes, 100 mg TDS follow. Or
okay.
else we'll go for suspensions mostly. Once tablets or adults will mostly
Mm,
go for tablets only. Mostly
yeah,
100 mg TDS.
okay, okay. And other query is whether have you, I mean, suba'itraconazole, do you think, have you used it or whether it achieves better levels? I was just asking that to Dr. Kriti as
It
well. So
it
because
Itraconazole.
suba'itraconazole, which is supposed to be super bioavailable itraconazole, have you used it or have you seen whether it will
Uh,
achieve?
Actually, itraconazole, we mostly do for posaconazole and voriconazole.
Okay.
Itraconazole, in a setting, I doesn't have that much experience with itraconazole.
Okay. Yeah, it is difficult to get ITRA levels as well. So, yeah. Thank you. Thank you,
Thank you.
Dr. Franklin, for making time and being a part of this webinar.
Thank you, ma'am. Thank you for this opportunity. It's great.
So that brings us to the end of the today's webinar series on aspergillosis. So I would take this opportunity to announce the next. So next I'll be having the controversies in AMSP, a debate series. This is the third in line, and this webinar is in collaboration with AMR Declaration Trust, and it will be on March 1st. The notification and the topics will be out soon, so watch out for this space. So again, thank you everyone for being with us, and I take this opportunity to thank all the speakers for making time from their busy schedules and be agreeing to be a part of this madness. So thank you, Dr. Kriti, Dr. Yash, Dr. Nikhil, Dr. Franklin, and Dr. Anjali and Dr. Harshvardhan once again.
Thanks, Dr. Akshatha. Thanks to all the audience and other speakers as well. Good night.